Okay, so I'm Dr. Rhonda Watkins,
And I'm Tom Clennell.
and we are your course chairs for this year. We're missing one who's away on maternity leave, Dr. DeBorja, but we are excited to welcome you to our conference this year. We have a lot planned for you. 2 days of learning on a broad range of topics in Peds Ortho, Peds MSK, Peds Sports Medicine. We have speakers from a variety of specialties, including orthopedics, sports medicine, rehab medicine, and neurosurgery. We'll also have some dynamic workshops for you on both days. So to get started, I'm going to share just a couple of announcements with you. So if you need to claim any credit, CME or CEU, you'll get an email tomorrow afternoon from the course. And it will contain a course evaluation that you will need to fill out within 30 days to claim your course credit. Okay, if for some reason you don't receive the email, you can reach out to us directly. We have a lot of CME, actually support from exhibitors this year, so please stop by in the courtyard to visit them at their different tables, okay? With that, I'm gonna get us started with our first speaker. How's everybody feeling? Ready for some good learning today? All right. Okay, so first off, we have Dr. Ishan Swaroop. He's an associate professor in our department, Peds Orthosurgery. He's a subspecialty trained pediatric orthopedic surgeon. He did his residency at Hospital for Special Surgery in New York and his fellowship at Children's Hospital of Philadelphia in Peds Ortho. He has special interests in scoliosis and other spinal disorders, hip conditions, and traumatic injuries. He serves as the director of Peds Ortho Trauma and the associate program director of our Pediatric Orthopaedic Surgery Fellowship here at UCSF. He's going to talk to us today on the topic of DDH, Perthes, and SCFE. Welcome, Dr. Swaroop.
He showed me how to do it. All right, good morning, everybody. Thank you, Dr. Watkins, for that introduction. All right, so we're going to jump right in and talk about 3 hip conditions that we frequently see as subspecialty, surgeons and as pediatric orthopedic surgeons and clinicians. And these are the ones that oftentimes present to your clinic as well, and obviously, try to go over key physical exam findings, imaging, basic imaging studies that we try to order, and go over some of the diagnostic algorithms that we use when we manage these conditions. So I have no disclosures relevant to this talk. So in kind of looking at this, I kind of label these as kind of the big 3 for pediatric hip. And so the 3 conditions that we're talking about today are going to be developmental dysplasia of the hip, leg calf Perthes disease, slip capitofemoral epiphysis. And specifically, we'll talk a little bit about epidemiology and definitions, etiology and risk factors, talk about presentation, what are some of the key findings in the history and physical exam, imaging, what type of imaging we obtain, what do we look for in that imaging, classification. This now kind of gets into more of the orthopedic realm, but still has some relevance when you're evaluating these patients back in your office after they've been seen by us, and then treatment in terms of knowing what these kids and families are undergoing for treatment for these conditions. So we'll first start off with developmental dysplasia of the hip. So in general, dysplasia refers to a spectrum of abnormalities in the structure of the femoral head, acetabulum, or both. And so, I usually tell families, just like anything in life, right, there's a spectrum of severity. And so the cup-shaped acetabulum may be just shallow, or the hip could be actually dislocated. So it really is a spectrum of conditions, and we just label them all as developmental dysplasia of the hip. In general, you need the cup-shaped acetabulum to articulate with the femoral head. That promotes its development. And if you don't have normal contact between the two, that's what leads to hip degeneration. And we'll talk more about that in a little bit when we talk about classification. So the incidence of DDH ranges across the population from somewhere between 1% to 7% of all newborns across several populations. Variations in incidence may be due to genetic predisposition. Certain ethnic and racial groups have a higher incidence than others. And then cultural practices as well. So for example, people have looked at it in Africa, for example, the incidence of DDH is about 0.06 per 1,000 live births, whereas in Native American populations, it's 76.1. And this, again, is a mix of both genetic predisposition as well as cultural practices. It is typically a unilateral condition. Most often, the left side is affected, and about more than half of the time, the left side is more affected. The reason we think that is because the left side is typically adducted against the mother's lumbosacral spine in utero, and so we think that because the left hip is more adducted, that's the reason why the left hip is more susceptible to DDH. It is associated with other packaging disorders. So packaging disorders are conditions that we talk about as occurring or developing in utero. And the most common ones we think about as being associated are metatarsus adductus, congenital muscular torticollis, and congenital knee dislocation. So whenever, if I see a kid for DDH, oftentimes evaluate their neck and their feet and their knees, and vice versa. If I see a kid for metatarsus adductus, I'll oftentimes look to see what their hips are looking like. So what are the kind of etiology and risk factors? So as I mentioned earlier, normal hip development requires the femoral head to be reduced in the acetabulum. And that contact pressure is what allows the acetabulum to develop. And so the classic risk factors that we talk about for DDH are female sex, firstborn infant, breech positioning in utero, and a positive family history. So in terms of each one of these, kind of listed them in a little bit of order of the ones that are most significant. So for female sex, generally, girls are about 2 to 7 times more likely to have dysplasia than boys. And we think this is likely related to circulating estrogen, mostly maternal sources of estrogen, which lead to ligamentous laxity. And then the firstborn, we oftentimes think so firstborns are twice as likely as secondborns to have developmental dysplasia. And this probably is related to the decreased elasticity in the uterus in a firstborn patient. Breech positioning, this increases the risk by about 4 to 24-fold, depending on which study you read. And then family history, first-degree relatives have about a 12 times higher risk of having dysplasia. If you have a first-degree relative with dysplasia, you have a 12 times higher risk of having dysplasia yourself as well. The other risk factors that have been noted in there are post-maturity. Post-maturity maybe it relates to the fact that the baby is too big for the uterus, and again is a bit more of a packaging issue. Higher birth weight, same concept. So if the baby's bigger, maybe that's a risk as well. And then there are some external risk factors as well. So these ones kind of relate to a little bit of the cultural practice that we were just talking about, or I was just mentioning earlier. So for example, swaddling in the extended and adducted position increases your risk. And it's actually interesting, in Japan, there was a study that was done in which they kind of nationally changed the swaddling practices, and they noted the rate of dysplasia decreased from about 1 to 3% down to 0.2%. So external risk factors do play a significant role. So kind of roomy sleep sacks for kids, swaddling the arms, not the legs. Those are all good practices for kids. So in terms of presentation, what do you guys evaluate for? What do we evaluate for? And I think first of all, it just starts with a thorough history, and it kind of focuses on all of these risk factors that we mentioned. So, birth history, family history, things of that nature. Every newborn, you guys know this better than I do, undergoes a physical exam, and so obviously a hip exam is a big part of it. We're going to have a workshop later where we'll talk a little bit more about physical exam, but the key ones that we look at are, first of all, range of motion, so I'll kind of go out of order a little bit. So first we look at range of motion. So the most important things to look at is abduction of the hips. So limited abduction is one of the most sensitive findings for a hip dislocation. It's a little bit more sensitive in older kids, actually, because you need time for tightness in the muscles to develop to appreciate that. But you can just imagine if the hip is not reduced, so we're talking about a dislocated hip, not, obviously they have DDH, but they have a dislocated hip. The range of motion differences are going to be obvious from one side to the other. So abducting the hips, so flexing the hip to 90, abducting. The other tests that we look at are femoral lengths. So this is the Galeazzi sign. So essentially you make sure the buttock or the lumbosacral spine is flat on the bed. You flex up the hips and you see, is there a differential in the femoral lengths? That's also a sign that we look at. Again, if you have one side being shorter than the other, that suggests that one hip is dislocated or subluxated. And then the other ones we oftentimes talk about, and these are the ones we always, you learn in medical school and training and all that, are the Barlow and Ortolani tests, right? And these are more provocative tests. And so we'll talk more about this in the workshop, but Barlow test is essentially flexing the hips, adducting them, and providing a downward force. You're trying to dislocate a reduced hip. And an Ortolani test is basically providing an upward force and abducting the hip, trying to reduce a dislocated hip. So easy way to remember is O is Ortolani. It's from out to in, and the other one is Barlow. And so that's kind of like an easy way that, that we teach our medical students and trainees. And then, of course, examine for associated conditions. So the quick exam, not quick, but a more thorough exam, but you can do relatively quickly, is making sure that the baby or the infant is able to look in both directions, feel the sternocleidomastoid muscle, make sure there's no signs of congenital muscular torticollis. I usually take a look at their spine, because sometimes you'll find sacral dimple or something else that might be associated. And then I also look to see their feet and make sure their feet look plantigrade and there's no metatarsus adductus. So once you have a child who, there's a concern for development dysplasia based on physical exam or based on family history even, or based on breech presentation, then we tend to obtain an ultrasound. And so an ultrasound is obtained primarily because the femoral head and the acetabulum is cartilaginous, and so you cannot really see it on X-ray. And so an ultrasound is typically obtained. Now the question that always comes up is, at what point should we be obtaining an ultrasound, right? And so I think there's going to be some variation in practice, but I think the general consensus is that if there's a concern for a dislocated hip at birth, then obtaining an ultrasound right away is the next move, because you want to initiate treatment right away. If there are some subtle risk factors, but the exam is okay, say there's a breech positioning, female, firstborn, generally what we recommend is waiting until around 4 weeks of age, because you want the hip to mature a little bit so that we're not over-treating patients and then getting an ultrasound. And then in general, we try to make sure that if you are getting an ultrasound, getting it before 6 to 7 weeks of age. Because studies show that if you delay treatment more than 7 weeks, their success rate of treatment just goes a little bit lower. So those are kind of the big time points to keep in mind when you're thinking about when to order imaging for an infant. So an ultrasound is an excellent tool to evaluate the immature hip. And then again, like I said, they're typically ordered if there's concern on exam or for patients with significant risk factors. And then an ultrasound is very confusing, and there is variability. And so the image there is from a review paper that we wrote a couple of years ago, but there's various angles that we measure. But the essential way that, again, to think about how we're looking at the hip is we're looking at the hip, we're looking at it sideways. And so, can you guys see my mouse there? Yeah. So on the upper part here, these are the abductor muscles. This white line here is the ilium, so this is part of your pelvis. This here is the acetabulum. And this obviously is the femoral head. And this is the labrum. So you're looking at the hip, but you're looking at it sideways. So imagine the child is laying on their side. And so the things you're looking at is the alpha angle, which is this angle here. And so you typically want this angle to be greater than 60 degrees. So you can imagine that the more vertical this line is, the better it is, right? Because that means the acetabulum is deeper, therefore the femoral head can be deeper in the acetabulum. This angle, the labrum, should be becoming more like this with time, kind of holding the hip in on the lateral side. And the last thing we look at is the percent coverage. So alpha angle refers to the acetabulum, beta angle refers to the labrum. And then the percent coverage is if you draw that imaginary line continuing from the ilium down, you want roughly more than half of the femoral head to be south of that line. And again, that goes to the concept that the more of the femoral head being in the acetabulum promotes the acetabular development, and therefore you're more likely to have a normal hip. And then x-rays, when do we get those? Well, we typically start to get those around 6 months of age. And the reason we get them around 6 months of age is because that's when the ossific nucleus, or the femoral head, starts to ossify. And we have population normals that we look at, which typically start around 6 months of age. And so that's when we typically get an x-ray. I'll talk more about that when I go through the algorithm for treatment. So for classification, ignore the stuff at the bottom of graph classification. That doesn't apply to most people in this room. Probably just a few of us that actually do research on this, but the ones at the top are the ones that are more important. So descriptive classification is probably the most important for dysplasia. And so basically, we either say the hip is reduced or dislocated. And then we also talk about whether the hip is subluxated. Now, located or reduced basically means the femoral head is within the acetabulum. Subluxated means the femoral head is partially out of the acetabulum, but may be reducible on a different view. So for example, if you get on an x-ray, on an AP view, it might be subluxated, but if you get a frog lateral view, it might be reduced. And then dislocated hip is one that stays totally outside of the acetabulum. And so those are really the descriptive words that we oftentimes will use in our notes, and you guys will read that when we're talking about these patients. So treatment. Treatment for indications for treatment kind of depend on what the presenting issue is. So if a hip is dislocated at rest, but it is Ortolani positive, or if a hip is dislocatable, so it's Barlow positive, or if there's an abnormal ultrasound by about 6 weeks of life, then we oftentimes will recommend treatment. So again, let me reiterate that. So if a hip is dislocated at rest, but it's Ortolani positive, if a hip is Barlow positive, so if it's a dislocatable hip, or if there's an ultrasound abnormality by about 6 weeks of age, we typically recommend treatment with a harness. And in North America, that typically means a Pavlik harness. So a Pavlik harness, most of you guys have probably seen these either on your patients or you've seen them at some point, but essentially it's a series of straps that hold the hip in a flexed and abducted position. So again, if you go back to what we're trying to accomplish, right, it's just pretty basic. Like I feel like as an orthopedic surgeons, we kind of like just distill things down to very basic things, but you want to just keep the hips flexed and a little bit abducted. Because if you do that, the femoral head is deeper in the acetabulum, and therefore the acetabulum can develop normally. Now, a Pavlik harness is a very successful intervention. So studies have shown that the efficacy of a Pavlik harness is somewhere between 75 to 90%. However, it does have some complications. And the most common complications that we see are femoral nerve palsy. So if you think about if you flex the hip past 90 degrees, your femoral nerve, which is on the anterior aspect of your hip, can get pinched. And so that's the reason why you'll see that when we put these on for families, we tell them that every day you got to make sure the kid is kicking. And by kicking, I mean like firing the quadriceps, so like think about kicking a soccer ball. And so that's the things, if you guys see them in clinic, oftentimes check for that, right? Is a patient actually extending at the knee and their femoral nerve therefore is working. The risk of femoral nerve palsy, and Ali will talk a little bit more about this, is more common in kids who have dislocated hips that you're treating in a harness, because again, it makes sense, right? Because you're trying to position that hip in a more extreme position, and therefore it's probably a higher risk of a femoral nerve palsy. These are reversible. It will come back, but if you notice it, the harness comes off and it stays off until the nerve recovers. And then in terms of duration of treatment and wean, again, quite a bit of variation in practice, not only in our own group, but throughout the country and definitely throughout the world. Generally, for even mild cases of dysplasia, majority of us will do full-time treatment for about 6 weeks. If it's more of a less mild case of dysplasia, so a dislocated hip or a subluxated hip, then we'll probably go longer with the treatment. And when I say probably, it kind of depends on the ultrasound until the ultrasound becomes normal, essentially, and the physical exam becomes normal. So that could be 9 weeks, it could be 12 weeks. And then majority of us in North America, this is based on a survey study, about 2/3 of surgeons in North America, will do a wean after successful treatment. So wean basically means we don't quit cold turkey with a Pavlik harness, we typically gradually go down. So that's the reason why you sometimes will see patients that are wearing a harness for 12 hours a day or 6 hours a day. It's because they're probably in the wean phase of their treatment. And then last slide on kind of dysplasia. So this really talks about, we'll go over the algorithm in just a second, but what happens if the harness fails, right? So I just told you the harness is pretty successful. And if the harness does fail, and what does failure mean? Typically failure means, no progression or no improvement in the ultrasound by about 3 to 4 weeks of treatment. We typically will go to a second-line treatment, which would be a rigid abduction brace. And so the most common brace that we use in North America is called a rhino abduction brace. It's essentially a rigid abduction brace, and it holds the hips out rigidly. It's not like a Pavlik where the hips can actually move, but it just holds the hips fixed. And even in cases that are Pavlik, quote-unquote failures, the rigid abduction brace can be successful in up to 90% of those cases. So it is quite effective as well. And so oftentimes we'll resort to that. And then if all of those things fail, generally by then the kid is about 6 months of age, that's when we start to think about operative intervention. So that could be a closed reduction or an open reduction in the operating room. So just in the interest of time, I know it's a bit of a busy algorithm here, but you can see, if you have an abnormal ultrasound or physical exam finding, then it kind of breaks off into these 4 categories here. So we'll start on this side. So if the hip is dislocated and reducible, then we'll do a Pavlik harness. If a hip is dislocated and not reducible, that's where we talk about treatment with closed or open reduction. Typically around 6 months of age is typically when we would start to do that. If we go to the next one, if they have kind of moderate or severe undercoverage, and the hip is dislocatable, we'll still go down and treat with a Pavlik. If a hip is kind of immature on ultrasound, but hip is subluxatable, then we'll typically say, let's reassess another ultrasound in a few weeks to see if the hip matures. And again, try to do that. So if you get your initial ultrasound around 4 weeks of age, we'll typically repeat it around 7 weeks of age. That way we can initiate treatment if it is still immature by that time. And then if it is just purely just an immature hip on ultrasound, so an immature hip essentially means that the hip is stable on your physical exam, but the alpha angle may be 58 degrees or 59 degrees, and it's a 2-week-old infant, then we'll usually say just reassess an ultrasound, again, around 6 or 7 weeks of age and see if that alpha angle improves so that we're not over-treating these patients. So that's the majority of the talk, because I think that's the most common thing that you guys see in primary care. But for the next 10 minutes or so, I'll go over some of the more rare conditions that we typically see in pediatric orthopedics. So we'll start with Leg-Calf-Perthes disease. So Leg-Calf-Perthes disease is a hip disorder that's caused by decreased blood flow to the femoral head. It essentially results in avascular necrosis of the proximal femoral epiphysis. So it affects primarily the epiphysis, so the very top aspect of the femoral head. It kind of goes through phases, which we'll talk about in just a second. But the blood supply goes away, then it's reestablished, and then it kind of goes through different phases of reossification and remodeling with time. So it's a relatively rare condition. It occurs in about 1 in 10,000 patients worldwide. The age of onset is typically between 4 to 8 years of age. It's more common in boys compared to girls, and it is more common in Caucasian children compared to East Asian or African American populations. And it is typically unilateral. In fact, it can be bilateral in about 10 or 12% of cases, but oftentimes we see bilateral conditions that look like Perthes. We then start to think about genetic conditions that might be in play, like epiphyseal dysplasias. And so generally, this is a more unilateral condition. So, oops, there we go. So the etiology is what I alluded to earlier. So it's some kind of an insult to the blood supply to the proximal femoral epiphysis. It's likely a multifactorial process that we don't still quite understand. There is probably some genetic predisposition involved with Perthes. There are some hypotheses about coagulopathies being associated in kids with Perthes. So for example, factor V Leiden is oftentimes found in these patients. So we think maybe there could be some microvascular or coagulopathic cascades that are leading to this. Oftentimes this condition occurs in kids that have some kind of hyperactivity disorder as well. So we think, is there some other etiology, maybe trauma-related? And then passive smoking or secondhand smoking has also been associated with Perthes. But again, no direct mechanism has been identified for any of these. The risk factors are kind of what I mentioned there. And then essentially kind of the other thing that we talk about is delayed bone age. So oftentimes these kids are more skeletally immature. And so that's something that we also have noted, but again, hard to tie to a mechanistic process. So how do these kids typically present? So again, this is kind of a 4 to 8 age group, typically boys compared to girls. They typically present with a limp, and it's usually worse at the end of the day. It's usually activity related, and it has more of an insidious onset. Occasionally you will see kids who also have a painless limp, and I think this is more related to the fact of just, being able to articulate what they're feeling type of thing. But clearly there's a limp, and so there must be some symptoms that are happening. So it can present as a painless limp as well. Physical exam is really telling in Perthes. So essentially what you typically see is for the affected hip, there's generalized decreased range of motion. And the most sensitive things that we find in practice are limited abduction and limited internal rotation of the hip. Sometimes they also have a Trendelenburg gait because that hip hurts. The differential diagnosis I've listed there. So again, if you see a kid with bilateral Perthes-looking hips, then we think about dysplasias. There is a condition called Meyer's dysplasia, which oftentimes looks like Perthes, but happens in younger kids. It's more of kind of an irregular ossification of the proximal femoral epiphysis. It's probably just a normal variant, but this is kind of like a 2-year-old that has an X-ray that looks like Perthes, but may not be Perthes. And then, of course, septic hip can sometimes look like it, and then skiffy, which we'll talk about in just a sec. So for Perthes, diagnosis is all based off of X-ray. And so we typically get an X-ray. In my practice, I do get an MRI for all these patients. One is to rule out atypical things, but I also look to see how much perfusion the femoral head has because it has some prognostication for what I tell families to do. An arthrogram is also really helpful, but obviously that's an invasive procedure that's usually done in the operating room. If you're going to be doing some other procedure, then oftentimes we'll do an arthrogram to see how spherical the femoral head is. And then for classification, we'll kind of just talk about the top part here. So it kind of goes through 4 phases. The initial phase of Perthes on X-ray, typically the epiphysis just looks very sclerotic. So oftentimes I tell pediatricians, just get an AP pelvis. Just don't get a dedicated hip X-ray, just get an AP pelvis, because then you have a normal side to compare to. And so if that side looks sclerotic, then you know something's going on and something looks different. Then after the initial phase, and essentially what's happening on a pathophysiologic level is probably at that point the blood flow has gone away, and therefore the bone there is deprived of nutrients and is becoming necrotic. The next phase is fragmentation. Fragmentation, it looks like what it sounds like. It says the femoral head starts to fragment. And at that point, probably what's happening is the blood flow has come back and it's removing, the osteoclasts are removing the necrotic cells or necrotic bone. And then it reossifies. So reossification is where now the blood flow is still there, the osteoblasts are working to reossify the femoral head, and then you have remodeling. Remodeling is where the head starts to kind of retake its shape. And so, as the hip is going through all these phases, I tell families this: there's no way in 2025 for us to make this go any faster. There's no biologic out there that speeds up this process. But what we can do is try to keep the head as spherical as possible as it goes through these phases. And the way you do that is, one is by controlling pain, so anti-inflammatory, so the child can still move their hip, be able to perform physical therapy. The other is by keep doing physical therapy and range of motion exercises. So what I mentioned earlier, right, they have limited abduction and internal rotation. You want to make that better. And so by pain control and physical therapy, if you keep the femoral head moving, think of it like rolling a Play-Doh, right? If you just keep rolling a Play-Doh, it stays round. So it's the same kind of concept. And the third concept is you want to keep the femoral head in the acetabulum, because you want the femoral head to have a template, which is the acetabulum, to stay round. And the analogy there is Jell-O and in a bowl, right? You put Jell-O in a bowl, it takes a round shape. Put Jell-O in something else, it takes that shape. And so you want to keep the femoral head contained in the acetabulum. And so the ways we do that is with physical therapy, like we talked about. Sometimes we'll do something called a adductor tenotomy, where you release the adductor tendon, put them in a cast. That's that cast that you can see on the upper image. And sometimes that's with surgery, right? Sometimes you actually have to do a femoral osteotomy where you actually manually, or a pelvic osteotomy where you manually make sure the ball is covered by the acetabulum so that it's staying contained. And then in just the last few minutes here, we'll go over SCFE. So SCFE stands for slipped capital femoral epiphysis. It's essentially defined as displacement of the femoral neck or the metaphysis relative to the epiphysis. So that's actually an important concept. The femoral epiphysis stays in the acetabulum. It's the metaphysis or the femoral neck that's actually moving out of place. And that's important because that's the reason why kids present the way they do. So oftentimes when they present, their hips are externally rotated. And on X-ray, it looks like it's in varus, meaning that this femoral head is lower compared to the femoral neck here. It is the most common adolescent hip disorder. So this, again, is a little bit of an older age group compared to Perthes, so more like the 9 and up group. It doesn't happen after your physes are closed for obvious reasons, right? That's why it's called slipped capital femoral epiphysis. The incidence is about 10 in about 100,000 cases. It's a higher incidence in boys compared to girls. And then this, again, has probably some genetic predisposition because it's higher in African Americans and Pacific Islanders. And interestingly, there is some seasonal variation too. So latitudes kind of north of New York City, it tends to occur more in the summer and fall. So we don't know exactly why that is. Could be activity related. Some people have hypothesized they're like a viral etiology. Unknown, more likely activity related, but that's something that people have seen. And then there can be, if it happens on one side, it can happen on the other side. And so oftentimes if you're getting an X-ray on one side, again, an AP pelvis is helpful because then you can, of course, see the other side as well. The etiology here, it's multifactorial. Mechanical forces acting on a susceptible physis is kind of what we say. The most common risk factors we talk about are endocrine disorders, so hypothyroidism being the most common one. Oftentimes I think about this in the very young kid that presents with a SCFE, not the 12-year-old regular kid where it might just be mechanical risk factors, but if it's like a 9-year-old, then oftentimes we're getting thyroid function studies on those kids to make sure. The classification of this, and for our purposes, again, I think we'll focus on the top two here. So it's either stable or unstable. Stable basically means they're able to walk on it or they're not able to walk on it. And that can be with or without crutches. Unstable means they're not able to walk on it at all. And this is helpful because it helps us tell you how quickly does this kid need to come in or be seen. So in general, we'll tell you for SCFE, send them to the emergency room. But unstable SCFEs for us in general are more of an urgency because the blood flow is at stake and the risk of avascular necrosis is higher. And then in terms of temporal slip or temporality, we have acute, which is usually less than 3 weeks of symptoms, chronic, which is more than 3 weeks, and then there's the acute on chronic, which is they've had long-standing symptoms, that then they have an uptick in symptoms. And then just to kind of close out this topic, so in terms of what do we do, or for you guys in particular, what are things to look at on exam and presentation? So these kids are those kids who keep coming back to your clinic with knee pain, right? If they keep coming back with knee pain, don't image the knee anymore. There's no MRI that's going to help you. If the x-ray is okay, look at the hip. And so examine the hip and get a hip x-ray just to make sure there's no SCFE. The history here is typically weeks or months of pain, typically in the knee, and we think that is because of a referred pain from the obturator nerve, which shares innervation between the knee and the hip, and so we oftentimes think that that's the reason why kids present with knee pain. And then on physical exam, the thing you'll notice is limited flexion and obligate external rotation with hip flexion. So you can see as you flex the hip, it falls out. So that's typically what you'll see in a kid with a SCFE. Radiographically, we see kind of a few things. You can see blurring or irregularity of the physis. This is Klein's line on an AP view. If you draw a line on the femoral neck, it should at least transect the epiphysis in some way, shape, or form. So you can see in this case it does not, whereas in this case it does. Those are all signs that there is a SCFE present. And then this is more, again, from a surgical perspective, we think about these as kind of severe. We think about them as stable and unstable and severity because it helps us figure out what's going to happen long-term for this patient and help counsel them as to what functional issues they may have long-term. And then in terms of treatment, for stable SCFEs, we typically will do in situ screw fixation. Essentially what you're trying to accomplish there, it's an epiphysiodesis. So you're basically trying to get the growth plate to close so that it doesn't keep slipping with time. And then in an unstable SCFE, this is the one, again, the kid cannot walk. This is more like a fracture because it's actually more of a dynamic situation where the epiphysis is moving relative to the metaphysis. There's a little bit of variation in practice. Some of us will attempt a closed reduction and fixation. Some of us will do an open reduction and fixation. And the reason where it's a bit more controversial and a little bit more time sensitive is because the risk of osteonecrosis for an unstable SCFE is somewhere around 45 to 50%. So it's quite high. And so therefore, there's a lot of implications there. And then lastly, long-term, how do these kids do? Majority of them will do really well. And even natural history studies have shown that people who have SCFEs as infants, or sorry, not as infants, as adolescents, will typically develop degenerative arthritis, typically in their 5th or 6th decade of life, which is not bad. And then, however, complications such as osteonecrosis can occur. And the more common one we see, especially in North America, is FAI. So these kids are pretty active. They'll go back to activity and they'll have pain or functional limitations related to impingement. Because again, right, we haven't really corrected the anatomy. And so they have impingement and therefore they could require subsequent surgery later on in life. So in summary, there are obviously several important causes of hip pain and hip disorders in kids. Newborns should be evaluated for DDH and ultrasound should be performed in patients with abnormal exam findings or risk factors. Perthes disease typically occurs in that 4 to 8 age group, and x-rays are usually helpful, especially if you have a kid with an unexplained limp. And then SCFE typically presents in a little bit of an older age group, typically presents with hip and or knee pain. And then these conditions can be managed appropriately with a timely diagnosis, but all of them have long-term implications. So this is one of the fun things about what I do is I actually get to follow these kids, sometimes pretend to be a primary care doctor and see kids over and over, and you kind of see how they do with time. So, yeah. All right. Thank you for that. We're going to do questions at the end, right?
Great, thank you, Dr. Sarup. So just for the audience, we're going to hold questions until the end of the HIP section for the morning. So just make a note of your questions. All the speakers will be here to answer them at the end. So we're going to move on now to our next presentation. Do you guys have access to the syllabus? It is available on the course website. And we have a QR code with the link to it that will come up during the break slides if you don't have access yet. So next up is Alex Wilson. She's a senior physician assistant in our Pediatric Orthopaedic department here at UCSF. She completed her master's in public health at Boston University and her MS in physician assistant studies at UC Davis. She has special interest in pediatric spine and hip conditions and is a great teacher. We're excited for her to share today on the topic of caring for infants in a Pavlik harness or rhino hip abduction brace. Welcome, Alex.
That's where. Okay. There we go. So, I guess we're not Ramirez or Wilson.
That's it, and then just arrow.
Yeah, and then we're gonna go from here.
Perfect.
Yep, you're all set.
Thanks so much. Okay, hi everyone. Thank you, Dr. Watkins. So I'll talk to you guys today about caring for infants in Pavlik harnesses and some of our older children in rhino abduction braces. I have no financial disclosures. We'll go over both the types, the harness and the brace, and what they look like and how we put them on. We'll talk about a little bit of a review of what Dr. Sarup already mentioned when we are indicated to use these devices. And then we'll talk about just care considerations, a lot about what we counsel families when we're starting these Pavlik harnesses or these braces. Some of the complications, which were a little bit discussed already, but we'll go over those and a couple others. And at the end, I'll kind of share with you the resources that we give to families when we are counseling them and they're starting out using a Pavlik harness or an abduction brace. So the two types of things we use most commonly in our clinic are the Pavlik harness and the rhino abduction brace. The Pavlik harness is a soft dynamic brace that allows kids to move. This is typically used in kids who are 6 months old or younger. And typically it's for hip dysplasia. There is one other use we use it for that you may see kids in your clinic for. Those are little babies who have had femur fractures and are under 6 months and can't be casted. The rhino abduction brace is rigid and fixed, so it doesn't allow as much movement. And it's typically used for patients who are 6 months or older. But there are some indications where we use it in younger kids. Dr. Sarup had mentioned where we have kind of had failure of our Pavlik harness. A little bit of a review again, but our exam findings, which we'll do in the workshop, are typically looking for our positive Barlow and Ortolani, asymmetric hip abduction, and one knee being higher than the other when we see our Galeazzi sign, that being positive. He already went over what we look on for the ultrasound, but essentially we typically get this between 4 and 6 weeks, and with a combination of these findings, if we see that there is hip dysplasia in any of that spectrum, we consider using this Pavlik harness. So a couple things we tell families, like not all of our babies are this happy in our Pavlik harness, so there's a lot of counseling that goes in, especially that very first visit. And one of the biggest things before we put the Pavlik on, we ask families to use just a very thin bodysuit or onesie that essentially has no legs. So those legs are naked inside the harness, and there's just a snap over the diaper. This allows the harness to fit best on the patients, and this is how we initially make it fit and kind of mark the straps where we want them. A lot of families will ask about strap covers or knee socks. The strap covers, you can see a picture of them on the right side of your screen, where the little rainbows are on those cloths. Those can go over the straps. They're absolutely unnecessary, but a lot of families do use them, and you may see them in your clinic. They do kind of serve two purposes. One is they keep the harness a lot cleaner. A lot of families get worried about the harness getting dirty, and as you all know, seeing babies and having some of your own, they're going to get dirty no matter what you do. So some families do like these. They also serve the purpose of kind of protecting their skin from the straps resting directly on their neck and in the areas where they don't have clothing. In the colder months, a lot of families get worried about their kid being cold if they're told, like, please keep your legs naked. And so there are these like very cute baby knee-high socks you can just order on Amazon. So some families will use these, and they're thin enough that they allow the harness to still fit properly. Dr. Zerupet also mentioned some of these sleep sacks. So a lot of families have, by the time their baby's about 4 to 6 weeks, they've already gotten in a routine of doing some swaddling or having them in a certain way that they sleep at night, that they feel like they've been successful. And so they'll ask about how do we continue that using this harness. There are many, many sleep sacks out there that are made to accommodate both the harness and the abduction brace. You can see this little girl with her little bunny, like she's probably in a rhino because it's very, very wide, but the sleep sack still covers it. So there's many options out there for families to use. A lot of parents will also say, I swaddle my baby, is that okay? I think we all kind of know at this point swaddling the arms is fine, but we always, even in babies who don't have hip dysplasia, want to keep those legs open and apart. And in the harness, they need to be able to fall open easily in that abducted position we've set them in. So they can certainly swaddle the arms, that's absolutely fine, as long as those legs can stay open. There's one here where you can see the baby has his arms down in a swaddle that just covers the arms, and then there's also swaddles out there that are made that keep the arms down but also have a cover on the bottom that's very, very wide. So there's many options out there. Another thing we talk about is just checking the skin. They're going to be in this Pavlik sometimes 23 to 24 hours a day. So we do ask the families, every so often, maybe every diaper change, just check around the areas where the brace or the harness is coming into contact with the skin, make sure it's not irritated. And then looking kind of where those skin folds are. So the knees are bent in a 90-degree position. So just checking back there and making sure there's not any irritation developing. A lot of families take off this harness if they're in it about 23 hours a day, their hips are stable. We often let them out of that harness about an hour a day where they can take a bath, take pictures of their kid without the harness on. This is another time they can check kind of all of those skin folds in all of those areas for any rash that's developing. Like I said before, it's going to get dirty, so many families are tempted to put this in the washing machine and clean it, but we really advise them not to do that. One is if it goes in the washing machine, then it's kind of hanging up all day to dry, and they're out of it for an entire day, which we don't want. If they throw it in the dryer, it's just going to shrink, right? And the Velcro essentially will fail. So we really remind families just spot clean only. It's going to get gross, but we can always give them a new one if it's beyond repair, but just spot cleaning only for the harness. Diapers, luckily the harness is made that you actually don't have to do anything to the harness to change a diaper. So there's a nice wide opening. You can kind of see this provider is showing how to change a diaper with the harness on. And the legs are open, there's nothing covering the diaper, so that can be changed easily. One thing we tell families, and if they've had other kids or have taken care of kids in the past where they kind of grab the legs, pull it up, shove the diaper under and change them, we kind of advise against that because we want to avoid anything where the knees are essentially coming together. So just like you would take care of a patient with clubfoot, you're kind of gently lifting their bottom to change the diaper rather than grabbing the legs in the harness. A lot of families too will ask, I've been breastfeeding or I'm bottle feeding, how do I hold my baby now that they're in this harness? Essentially, it's just finding a position that's comfortable. So just reminding them they can still do everything they did before. They may just need more support or a different way to hold their baby, so it's comfortable for both them and their child. Dr. Sroop talked a little bit about this already, but one of the biggest things we tell families and you guys in your clinics to look out for is a femoral nerve palsy. So as he had mentioned, we really want to see that baby kicking at the knee. So when we see families for that first visit and we're putting them in the harness, we remind them of this and kind of say to them, every time you go to change a diaper, just check that that baby is kicking at the knee, right? Tickle their foot, kind of get them stimulated, and if you really cannot get them to kick at the knee or their leg kind of looks limp and it's not moving, that harness should just come off. Usually what's happened is they've gone through a little growth spurt and we haven't seen them back, and the knees have gotten and the hips have gotten flexed to greater than 90 and kind of look towards an M shape. So if you pull down on their knees, you really can't get that tabletop 90-degree position. That, essentially once that harness is removed, almost all of these cases resolve. When we look at the literature, we see that the incidence of this is somewhere between 2 to 10%, although we don't know if it's reported all the time. But we know that just simply removing the harness, letting the nerve recover is the best treatment, and then actually restarting the Pavlik rather than abandoning it altogether. And just reminding them this is temporary, it will resolve, and they can still go on with this treatment. Another risk we see is osteonecrosis. So as we have mentioned before, essentially we're losing some blood supply to that femoral head. And we see incidence similar between 1 and 11%. And we know that there are certain risk factors that make this more likely, the biggest one being severity of hip dysplasia. So these dislocated hips on that end of the spectrum are more likely to develop this. Usually we see that this is can be a result of improper harness fit or hyperabduction in the brace. And unfortunately, this can lead to long-term permanent changes in that femoral head that can need surgical indication or surgical treatment later on. For you guys and for parents, we just let them know the biggest thing to prevent this is just detecting it early and making sure the harness is fitting the way it was set initially and it's properly fitting. In this picture, you're just kind of seeing an x-ray of how that has developed over time in a patient that had developed osteonecrosis. They're referring to it as AVN here. And they can see that patients who fail their pelvic harness, so as Dr. Sarup mentioned, when we put patients, especially those with dislocated hips, into a harness and it reduces, we do see a higher incidence of this happening in patients who initially were on that end of the spectrum where their dysplasia was more severe, and this can be a predictor for this developing in patients. The last complication is pelvic harness disease. So in a similar way, when we see failure of the pelvic harness, we can see some posterior lateral remodeling of the acetabulum in patients that have pelvic harness disease. Essentially, they've been in this pelvic harness and they're not responding to this. Most of these patients have dislocated hips, and this hip is not reducing well into the acetabulum. And the reason we care about this is because these patients often will go on to need a closed or open reduction later, and it can make that intervention harder later down the road. This is the biggest reason why, if we see a patient and we have them in a pelvic and we get an ultrasound at 2 weeks and at 4 weeks and we're really not seeing any change or improvement, we abandon the harness and we try something else. And one of those things we use is the rhino abduction brace that Dr. Sarup had mentioned. So abduction bracing, this girl looks very happy and she's standing up in her brace. So these typically are used in kids that are older. We typically don't use it as much during the day, so most of these patients use it for nights and nap time when they're asleep. These older kids are going through a lot of developmental stages, so we want them to be able to do those things during the day, and the brace is typically, but not always, used when they're sleeping. It's used usually around 6 months and can be up to 2 years, although some patients will tolerate it longer, especially if they've already gotten used to it, and we started at a really young age. And when we talk about taking care of patients in this brace, it's a little simpler than the Pavlik. It has less straps. It's essentially from your waist down. There's a strap around the baby's or the kid's waist, and then 2 straps, 1 on each leg. It's a smooth foam and a smooth plastic, so it's much easier to clean than the Pavlik that is cloth. And same thing, just kind of spot cleaning only. The biggest thing we run into with patients who are in these is we don't see them as often as we are checking on our pelvic harness patients. So we see them sometimes 4 to 6 months apart from each other, and just making sure if they have this brace in their home and they feel like it's not fitting properly, just to come back to our clinic so we can get them the next size up if that kid has grown a lot. In terms of counseling overall for both the Pavlik and the abduction brace, I think the biggest takeaway that I've learned from treating these families is that this first visit, when they're starting this treatment, is very overwhelming and often very emotional. And you may see some of that if they're coming to you for their well baby checks and they've just been started in this harness. So I think the biggest thing I remind families is that just being consistent is probably the best thing, so that both the baby and you as parents and anyone who's caregiving for this child can get used to this new routine. They have a brand new baby, sometimes it's their first child, and it's a lot for them to take in that first visit. And especially also patients who end up in our rhino braces that are older. A lot of families worry because those kids have stronger opinions about things. They can learn to take off the brace and it becomes a little bit of a fight. And I think some parents give up. But I've found that parents who just stay consistent do really well. Some parents will say to us, we get the brace out and we get our pajamas out and we're getting ready, and they just see that brace and they know it's bedtime, right? And those are the families that do really well. So just reminding them it's temporary, it's not forever, and just to be consistent so that they can have success with this treatment, which hopefully will prevent a bigger surgery or more treatment later down the road. A lot of families will ask about tummy time, so can I still do tummy time? Do I have to take off this brace or this harness to do it? And the answer is no, they can absolutely do tummy time with it on. Some kids, like even not in a brace, hate tummy time when they're little, and so just reminding them to use different strategies to extend their tolerance. They can roll up a blanket, put it under their chest, and they can usually last a little bit longer. In our families who spend like an hour out of the brace or in the weaning phase and are not in that pelvic harness for a full day, they can certainly use that time as well for letting them practice rolling and all the things they're starting to show signs of doing. In that regard, some parents will ask, if they're in this brace or this harness all the time, is it going to slow them down? Are they going to not reach the milestones like my other child or not on time? And I think just reminding them that there really is no evidence that kids don't meet those milestones or are delayed who are undergoing these treatments. And a lot of families will relay, like, as soon as we stopped the pelvic, they really started rolling, right? They will catch up, they will meet those milestones, and just reassuring them of that. We give patients like 2 big resources when they come to us for their visit. The first is hipdysplasia.org. This is like a very comprehensive website that has literally everything you'd ever want to know about taking care of a baby with hip dysplasia. It has like down from like the sleep sack, what you use, the carriers you can use with the pelvic, and it really even shows like videos of how to change diapers, how to put the pelvic on. So it's a really, really comprehensive resource for families. Orthokids.org is more informational, but has a lot of information about hip dysplasia and the spectrum of treatments that we use in pediatric ortho. And that's it. Thank you.
All right, thank you, Allie. Okay, so we're gonna move on to Dr. Ramirez. It's my pleasure to introduce Dr. Faustine Ramirez. She is an assistant professor of pediatric orthopedics here at UCSF. She's a primary care sports medicine provider. She completed her medical school training and pediatric residency training here at UCSF and did her sports medicine fellowship at Stanford. She has special interests in musculoskeletal ultrasound and the care of adolescent female athletes. She was an accomplished collegiate athlete herself, so quite fitting. And she's going to talk to us today on the indications for ultrasound-guided hip injections. Welcome.
Let's get you out of here. That should be you. You're all set.
Okay, great, thanks. Thanks, Dr. Watkins. I'm really excited to be speaking with all of you about this topic. So I have no disclosures. We're going to start off with a case today. So 16-year-old high-level ballet dancer presents to clinic with insidious onset of anterolateral right hip pain for 6 months that is exacerbated by hip flexion. She also complains of the hip occasionally feeling stuck. She has been modifying her dance activities due to the pain. She has been doing physical therapy for 2 months with minimal improvement, but her pain has been hindering her progress in physical therapy. Her exam is notable for pain with hip flexion and internal rotation and a positive fader and scour test. So what is the best next step? A, MRI to rule out a femoral neck stress fracture. B, MRI to evaluate for a labral tear. C, continue physical therapy and activity modifications. D, consider an intra-articular hip injection, and E, all of the above. So I'd like you to take a minute, chat with your neighbor, and see what you think the best next step would be for this patient. I'll give you a second. Okay, I'm hearing a lot of great discussion, which is awesome. So the correct answer here is E, all of the above. And we'll go over some of these very briefly. In this patient who is a high-level ballet dancer with a lot of hours of activity per week, you should absolutely be worried about a femoral neck stress fracture and any stress or bone stress injury. Her exam does point more towards a labral injury, but the exam maneuvers are not the most specific, and with any type of intra-articular hip pain, you could get pain with all of those maneuvers. So you absolutely should be thinking about a femoral neck stress fracture. You should also be worried about a labral tear. You're going to be hearing a lot more about that from different speakers. We'll go over that injury in a little bit more detail further along in the presentation, but some of her findings are concerning for a labral tear. Because we're more worried about a labral tear than a stress injury, it would be appropriate to continue physical therapy and activity modifications, but if you were more worried about a femoral neck stress fracture, then you would shut her down completely. And then you would also consider a hip injection in this patient. So let's talk a little bit more about that. So case continued, MRI is obtained, which confirms she has a labral tear. Due to inadequate improvement after 2 months of physical therapy, she is referred to a hip surgeon who recommends arthroscopic labral repair. However, she has very important rehearsals that are coming up and several big performances in the coming months. So she would like to postpone surgery until she has a break in her dance schedule. So which of the following is a potential indication for hip injection in this patient? A, to confirm her pain is truly originating from the labral tear. B, due to inadequate response to physical therapy. C, to maximize non-operative management before considering surgery. D, to improve her pain so she can make progress in physical therapy. And E, to improve her pain so she can finish her performance season. Or F, all of the above. So again, take a moment to, chat with your neighbor, never mind. But we're gonna go through all of these. These are all appropriate indications. And you may have guessed that I tend to go with all of the above. So let's go through and talk a little bit more about each of these throughout the presentation. So to give you a big overview of the types of hip injections we'll be talking about today, we'll be focusing on intra-articular hip injections, iliopsoas bursa and peritendinous injections, and greater trochanteric bursa or gluteus medius peritendinous injections. There are other types of hip injections. I would say these are the most common ones that we typically consider, although there are a few other more specialized types of injections. But of all of these, the ones that we'll be talking about the most today are the intra-articular hip injections. So we'll go through each of these and some of the more common clinical indications. So starting with intra-articular hip injections, so this diagram here demonstrates the different types of injections we'll be discussing, and the letter D corresponds to an intra-articular hip injection. So this gives you a sense of the anatomy here. And the picture to the right is an ultrasound image of what the injection would look like. So just to orient you, the A is the acetabulum, the H is the femoral head, and the N is the femoral neck. And you see, I don't know, can you see my pointer here? This bright line overlying the femoral head and neck is the hip capsule. And then you have a lot of musculature overlying the hip joint, notably the iliopsoas muscle here. And the arrow indicates the direction of the needle. So the ultrasound probe would be oriented in a slightly oblique orientation here, and you position it over the femoral head and neck, and you aim for the head-neck junction. And the goal is to inject the medication underneath, you get into the hip capsule at the head-neck junction. So that's the injection target. This is the most common approach for ultrasound-guided intra-articular hip injections. And you may be feeling like this is very close to the very important neurovascular bundle. It's a little bit lateral to that, so it's we can use different tools on ultrasound to make sure that we're avoiding important vessels, and we can visualize the vessels and the neurovascular bundle with ultrasound, and that's something we certainly do before injecting when we're getting our landmarks. But you can see it's actually a little bit more lateral here where we're injecting, and so there's no nerves or vessels in my field of view here, and I can use the ultrasound tools to avoid those. So what are some of the common indications for intra-articular hip injections? So one of the most common ones is femoroacetabular impingement, and we'll be hearing a lot about that today. A labral tear is also a common indication for an intra-articular hip injection. Less common would be hip dysplasia on the mild or borderline side. I don't want you to leave this talk thinking we treat hip dysplasia with injections. Legitimate hip dysplasia, we've talked a lot about the different treatment options, but if it's a case in an older patient that's on the milder side or more borderline side, or even in the setting of hip microinstability, we sometimes do consider intra-articular hip injections as part of either the diagnostic or the therapeutic interventions, as well as in juvenile idiopathic arthritis, not something that I typically treat in sports medicine, but in rheumatology, our rheumatology colleagues sometimes do treat JIA with injections with potent corticosteroid anti-inflammatories. So we're going to touch a little bit more detail on the first two, which are the more common indications for these injections. And you'll hear a lot about these, so this is going to be more of a big picture overview, but I do want you to know what we're talking about here and have a sense of these different conditions. So FAI, or femoroacetabular impingement, typically presents with gradual onset of anterior hip and groin pain in a C-shaped band around the hip, typically worse with prolonged sitting, often positional and activity related. It may be associated with a labral tear, but not necessarily. And on exam, you may see limited flexion and or limited internal rotation, as well as pain with those maneuvers, a positive Fader and Scour test. And we'll be going over these exam maneuvers a little bit later this morning in the hip workshop with Dr. Wong and I. So if you're interested in learning more about these, would love to join you there. So workup typically includes X-ray and MRI. You may start with an X-ray, and if the patient's not responding to conservative management, pursue an MRI. And treatment conservatively typically starts with physical therapy, NSAIDs, either as needed or a short course of anti-inflammatories, rest or activity modifications depending on the patient's activity level, potentially injections, and arthroscopic surgery, and you'll be hearing more about that next with Dr. Wong. So when would we consider injections for these patients? So if they've had an inadequate response to physical therapy, so typically I recommend at least 6 to 8 weeks, if not a little bit longer, before considering injections. So even up, 8 to 12 weeks of regular physical therapy, and really important to make sure that the patient is not just going to the sessions, doing the exercises regularly on their own, that they've been adherent, that they're not just showing up for physical therapy once a week, because that's not typically going to be enough. Sometimes patients have too much pain to even do the physical therapy. So if they have too much pain that's limiting their progress, that could be another reason why you consider a hip injection. Often we pursue diagnostic injections for FAI or for labral tears, which we'll talk about next. So anterior hip pain can be quite complex, and it can sometimes be difficult to distinguish between intra-articular and extra-articular causes of anterior hip pain, such as iliopsoas, tendinitis, or bursitis. So injections can be very helpful in that setting. Sometimes we only use anesthetic, or sometimes we use a combination of anesthetic and therapeutic medicines, which we'll talk about a little bit later. But in that setting, if you're doing it for diagnostic purposes, we would typically do a physical exam and try to provoke their pain with provocative testing, ask for a pain score, and then after the injection, I would typically repeat those same maneuvers and ask for their pain score afterwards. And then I'm looking for some improvement in their pain scores after the injection. And we would expect to see pretty immediate improvement with the anesthetic medicines that we're using. They have pretty short onset of action. So I typically look for at least 50% improvement in their pain scores. Surgeons may have different thresholds, but that's generally a positive response if they're seeing more than 50% improvement in their pain scores. And often this can be helpful for surgeons who are considering surgery to treat FAI or a labral tear to really confirm that the pain truly is coming from the hip joint, from the labrum or from FAI, because hip pain can be complex, and before proceeding with a big surgery, especially in a younger patient, it can be really important to confirm. And then sometimes patients, realize that they may need surgery to treat their condition, but it's not a good time for them, either because they are, in school and want to wait for the summer, or want to be home from college. They're in their seasons and they want to wait until a better time. And so in higher level athletes or performers, I often will consider injections to help, manage their timelines with their different sports. So if they, like the ballet dancer in the case, have a lot of rehearsals and performances and just want to get to the end of their performance season or to their sports season to a time that's more convenient for them, sometimes we can use injections in that setting. So again, athletes in season, if often have variations in their seasons, and so for timing purposes. So those are some of the reasons I might consider an injection in FAI. And labral tears, very similarly, are often going to be seen in the setting of FAI or in the setting of hip dysplasia. Will also present with either acute or gradual onset of anterior hip or groin pain. Often is activity related, and they may have mechanical symptoms such as locking or catching or a feeling of the hip feeling stuck, as the patient did in this case. And on exam, they'll typically have pain with hip flexion and or internal rotation, and they may also have a positive Fader and Scour test. Workup would also typically include X-ray and MRI. And treatment is very similar to FAI with physical therapy, NSAIDs, rest or activity modifications, injections, and arthroscopic surgery. And I would consider the same indications here for a labral tear for injections. So either inadequate response to physical therapy, too much pain to pursue physical therapy for diagnostic purposes, or to delay or postpone surgery, or an athlete in season. So the next injection that we'll be talking about is iliopsoas bursa or iliopsoas peritendinous injection. So on the diagram here, this corresponds to the letter A. So this is slightly more proximal to the interarticular hip injection. So here the ultrasound probe will be directed in a more transverse direction, usually parallel to the inguinal ligament. And this is an ultrasound picture that demonstrates the approach for iliopsoas injections. So just to orient you, to the right of the screen is lateral, to the left of the screen is medial. Here you do see our neurovascular bundle, so medial to where the injection target is, you'll see the femoral artery, and your vein and nerve will be in that area as well. The ILP corresponds to the iliopsoas muscle, and this white structure here on the ultrasound, what we call hyperechoic region, is the iliopsoas tendon. So typically the needle's directed in between the tendon here and the bony prominence here. So this is the iliopectineal eminence, or sometimes just adjacent to it. And so the needle is coming from lateral to medial, and just adjacent to the iliopsoas tendon here. So some of the common indications for this injection are iliopsoas tendinitis or bursitis, as well as internal snapping hip syndrome. I'll just be going over the first two today, but just so you're aware of what internal snapping hip syndrome corresponds to. This is typically where the iliopsoas tendon is snapping over the underlying bony prominences of the pelvis, so it may be the iliopectineal eminence or the anterior aspect of the femoral head, and so this typically presents with just what it sounds like, snapping of the hip, and it may or may not be painful. And there are two types of snapping hip, internal and external. We'll review external in a moment. So iliopsoas tendinitis and bursitis will typically present with gradual onset of anterior hip pain, often worse with flexion, often activity related. And on exam, patients may be tender to palpation over the iliopsoas tendon, may have pain or weakness with resisted hip flexion, and may have a positive Stinchfield test. Workup here typically starts with X-ray. You may consider an MRI or ultrasound, especially if the patient's not improving with conservative measures. And treatment typically starts with physical therapy, NSAIDs, rest or activity modifications, and injections. Here, when I would consider an injection for these patients is if they're having an inadequate response to physical therapy, or again, too much pain with physical therapy. And for diagnostic purposes, this can be really helpful, especially when the diagnosis is a little unclear. As we've talked about, anterior hip pain can be complex, can often be multifactorial. So I may have patients who actually have both intra-articular and extra-articular anterior hip pain at the same time. So intra-articular might be FAI or labral tear, tear. Extra-articular anterior hip pain might be some iliopsoas tendinitis. And in practice, I often will do both of these injections. I do separate them by at least 4 weeks if I'm trying to do the injection for both diagnostic and therapeutic purposes. So if it's unclear based on the MRI findings, based on the exam, where the pain is originating from, it can be really helpful to start with either one or the other, and to assess the response to in the patient, and to give them a little bit of time to make sure the medication has time to take effect. And often there can be multiple causes of hip pain, and I really counsel patients that this may alleviate a portion of their pain, but there may still be some residual pain, and that's helpful, just as helpful as if there was complete response, because then we know that there's some pain originating from the hip joint and some pain that may be originating from the hip flexor tendons. So we'll talk a little bit more about timing, but I do separate those out. But in practice, I often will pursue both of these injections if the diagnosis is unclear. Next, we'll talk about greater trochanteric bursa or gluteus medius peritendinous injection. So on the diagram here, this corresponds to letters B and C, and those are just slightly different locations. C is more at the greater trochanter, and B is just a little bit more proximately around the gluteus medius tendon. And this ultrasound picture again shows the orientation of the needle. So to the left would be anterior, to the right is posterior. So here I'm located transversely over the greater trochanter, and you have the gluteus maximus muscle here and the gluteus medius muscle, and those the gluteus medius and minimus insert at the greater trochanter, and you have the gluteus maximus and IT band that come over those, and there are a lot of small bursa in between those tendons, and so when we call the greater trochanteric bursa, it's really the subgluteus maximus bursa, and that's the typical injection target for this injection. And so you can see my needle trajectory here would be from posterior to anterior, aiming for that thin dark stripe, and that's the bursa in between the two tendons. So the indications here would be gluteus medius or gluteus minimus tendinitis, greater trochanteric bursitis, or external snapping hip syndrome. So this is the other type of snapping hip. And external snapping hip is typically when the IT band is snapping over the greater trochanter, and that may or may not be painful. So we won't talk too much about that one, but just wanted you to be aware of that diagnosis. So greater trochanteric pain syndrome is really an umbrella term that includes gluteus medius and minimus tendinitis, as well as greater trochanteric bursitis in young patients, and older patients would also include some tendinopathy or partial tearing of those tendons, but I don't typically see that in my pediatric population. So this typically presents with gradual onset of lateral hip pain, which is often activity related, may be worse with prolonged standing or sleeping on the affected side. On exam, patients may be tender to palpation over the greater trochanter, may have pain and or weakness with resisted hip abduction, and may have a positive Ober test for their tight IT bands. Workup would start with an X-ray, and again, you would consider MRI or ultrasound if they're not improving with conservative measures. And treatment typically starts with physical therapy, NSAIDs, restor activity modifications, and injections. And the indications here for injections are going to be very similar to what we've seen, but again, if they have an inadequate response to PT, for diagnostic purposes, although I do these less often for diagnostic purposes because there are not as many other causes of lateral hip pain, but sometimes for posterolateral hip pain there can be some confounding findings on exam that might be concerning more for proximal hamstring tendonitis or maybe piriformis syndrome. So sometimes it can be helpful for diagnostic purposes, but more so for therapeutic purposes, or if they're in season and you want to maximize non-operative management. So those are the main clinical indications. Now I'd like to go over a little bit about the procedural logistics. So you can counsel your patients about what this might look like if they have questions, and you have a sense of what they might expect when they're seeing me for an injection. So I use ultrasound guidance for these. These are typically in-office procedures. We do use local anesthetic. There's no general anesthesia, and these don't typically require full nerve blocks. It's really just a little bit of local anesthetic. can be done with aseptic technique, so not true sterile technique like in the operating room. And just duration, typically these are a routine 30-minute visit. The setup takes the longest, so the setup and the injection might be about 15 minutes. The injection time itself is maybe less than 5 minutes, but everything else, preparing, scanning in advance, consenting the patient, et cetera, it really all takes the longest. So in terms of medications used, for local anesthetics, we typically use lidocaine, ropivacaine, less often bupivacaine. These have different onsets of action, so lidocaine is often used because of the shorter onset of action within 30 to 60 seconds, so really helpful for local anesthetic purposes. But if I'm doing the injection for diagnostic purposes, I try to incorporate some ropivacaine because it has a longer duration of action. So if I want the patient to go and test the hip out at home, do something that would typically be painful and see if it feels better, the ropivacaine can be helpful because it lasts a little bit longer. And then in terms of therapeutic medications, corticosteroids have traditionally been used, although we've been using NSAIDs more recently, so ketorolac injections, and those can both be used intra-articularly and also peritendinously, and those have a lot of benefits, which we'll talk about in a moment. And in terms of corticosteroids, triamcinolone, dexamethasone, betamethasone, and methylprednisolone. Typically, these have a duration of action of about 6 to 12 weeks, but it's really patient dependent, so sometimes shorter, sometimes can be longer, several months, if not longer than that. So what are some of the benefits of these injections? Let's start with ultrasound guidance. Historically, hip injections have been done under fluoroscopy or CT guidance, which have a lot of downsides. So ultrasound guidance is really great because it avoids exposure to radiation and contrast, which are typically used for fluoroscopy and CT. Ultrasound allows better soft tissue visualization and real-time needle visualization. So you can visualize your needle, aiming towards your target, and you can visualize the medication being injected and ensure it's going to the right place, because sometimes your needle can get, as you're starting to inject the medication, can move around, can get pushed out of these tighter spaces, especially bursa, as they get filled with fluid, get more full, and so the pressure can push the needle out, so you ensure that you're staying in the right location throughout the duration of the injection. Studies have shown that it results in more accurate needle placement compared to landmark guidance. And some studies have shown that image guidance, such as ultrasound, may be associated with less pain on injection, improved patient satisfaction, and better short-term clinical outcomes when compared to landmark guidance. So some benefits of these injections for diagnostic purposes, as we've talked about, can really be helpful to distinguish between intra-articular and extra-articular causes of hip pain. For example, hip joint versus iliopsoas can be a really helpful tool. The anesthetic has onset of action within a few minutes, as I've mentioned already, and so I typically, if I'm doing the injection for diagnostic purposes, we'll use lidocaine, and we'll do the before and after exam, and I'm looking for at least 50% improvement. I'll also ask the patient to keep a pain diary, because sometimes the pain may not be I may not be able to provoke it on exam. It may be something more dynamic that they feel only during sports or only during certain activities that we cannot reproduce in office. If it's only when they're going upstairs or playing soccer, I may not have access to a treadmill or to a stairwell. So I will also ask them to keep a pain diary and mark down on a daily basis until the next follow-up visit what their pain scores are and where they're feeling the pain, what types of activities exacerbate the pain, so that they can really report back in 2 to 4 weeks how they're doing. It can also be helpful to confirm suspected diagnosis if there is post-procedural pain relief, as I've mentioned, and can also help facilitate pre-surgical planning. And a lot of surgeons find this to be a really helpful tool when deciding whether to proceed with operative intervention. And sometimes we do see things on MRI, for example, labral tears, that may or may not be symptomatic. And so this also can be very helpful when we see abnormal findings on the MRI to confirm whether those are truly the cause of the patient's pain or just incidental findings, and this happens quite a bit. Other benefits, so for therapeutic purposes, as we've seen, injections can help improve pain or other symptoms, can help improve function, can facilitate physical therapy if it is limited by pain, and can help avoid or delay surgical intervention. So what are some of the risks? So procedural risks, these are things that I counsel all my patients about before every single injection. So infection, quite low, typically cited less than 0.1%, but it certainly is a risk. And when you think about inserting a needle into someone's joint, so the concern is for septic arthritis or soft tissue infections, bleeding, allergic reaction to injectable medications, pain or damage or injury to any soft tissues, vessels, and nerves, but this is really minimized with the risk or with the use of ultrasound. In terms of medication risk, there are some risks associated with all the medications that we use. So for local anesthetic, very rare, but cardiac and CNS side effects with unintentional intravascular injection. So again, minimize with the use of ultrasound where we can visualize the vessels and ensure that we're not injecting intravascularly, but very rarely this can occur. Chondrocyte toxicity and tenocyte toxicity. So this is really something important to consider, especially in our pediatric population. Important considerations when injecting these local anesthetics, especially intra-articularly, is that there's some research that suggests there is potential chondrocyte toxicity, and so wanting to minimize that, for the long term when thinking about their overall cartilage health. Risks of NSAIDs such as ketorolac. So we've been using this medication more recently because studies do suggest that NSAIDs do not affect the cartilage, synovium, or chondrocyte viability. And so generally, safer profile when compared to corticosteroids. And so we've been using these medications a lot more, especially in younger patients. There are impaired hematologic, gastrointestinal, and renal function. So thinking about your typical NSAID side effects, however, although there's some systemic absorption, much less than if you were taking these medications orally. So it's generally thought to be pretty safe. I do avoid these medications if patients have these underlying conditions, especially renal dysfunction, may come up in pediatric populations or GI concerns, or sometimes I'll have them check with their subspecialist to see if it would be safe to get an intra-articular injection before proceeding if they do have underlying medical conditions, but those are less common in pediatric patients, but definitely something to ask about when counseling about these injections. So thought to have less systemic adverse events rather than oral NSAIDs, but there is also a risk of a post-injection pain flare, but generally a pretty good safety profile when compared to corticosteroids. With corticosteroids, we do see facial flushing, we see soft tissue atrophy and or hypopigmentation. Systemic effects, there are some systemic effects even with injections of corticosteroids, so we counsel about hyperglycemia, hypertension, decreased bone marrow density, and adrenal suppression. There is a risk of tendon rupture, again, so important to counsel patients about this. And then really important consideration with our pediatric or young adult populations is that there's a risk of accelerated cartilage loss, subchondral insufficiency, fractures, more rarely osteonecrosis, and very rarely rapid joint destruction, but thinking about overall cartilage health and chondrotoxicity of corticosteroids, and again, a post-injection pain flare. So these are all important considerations, especially with our pediatric patients. These are the contraindications to corticosteroid injections, absolute and relative, that I do counsel patients about, and just, they're in your syllabus for your reference. And then important to comment on limitations, so potential lack of efficacy. So this is always a possibility that I counsel my patients about. We hope that this will help improve your pain, but perhaps, if we're doing this for diagnostic and therapeutic purposes, we may not be targeting the right etiology of their pain. The medication may not work well for them, or it may, I think the bigger limitation is that it's short-term pain relief for some patients, right? So we say 6 to 12 weeks, it's very variable, patient-dependent. And ultimately, this will not fix their underlying problem if there's an underlying biomechanical and or structural issue. So it can have a lot of benefits, as we've seen, a lot of great indications, but it may not address or fix the underlying problem. And that may be something that either needs to be addressed with physical therapy and potentially surgery. Continuing the case, these are all the indications that we reviewed today that could be potential indications for hip injection in the patient that we saw. And these would all be appropriate, and in some patients they're all appropriate, and sometimes they're more patient-specific. But we kind of went through all of these, so I don't think we need to go through them again in more detail. But these would all be, reasons to consider injections, and that you could always refer patients to a sports medicine specialist to discuss if you think your patient may benefit from an injection. Thanks so much for your time.
Great, thank you, Dr. Ramirez. I'm going to introduce our next speaker, Dr. Stephanie Wong. Dr. Wong is a pediatric orthopedic surgeon within our department. She's an assistant professor in the department. She's board certified in ortho surgery and has had subspecialty training in sports medicine and hip arthroscopy. She completed her orthopedic surgery residency training here at UCSF, and then she did sports medicine fellowship at Rush University in Chicago. She specializes in arthroscopic treatment of the hip, shoulder, and knee injuries. She serves as co-director for Women Sports Medicine Center at UCSF, and also is the associate fellowship director for our sports medicine and shoulder surgery fellowship. Welcome, Dr. Wong. She's going to be talking to us on hip arthroscopy in the pediatric population.
How are you? So you're right. Oh, that's you, right? You're all set.
Thank you. Thank you so much, Dr. Watkins, for that really kind introduction, and welcome everybody, and thanks for being here today. Today I'm going to talk about hip arthroscopy or hip scopes and when we use them kind of in our pediatric adolescent age patients. So this is my disclosure. I don't think necessarily relevant to this talk. So in terms of when do we do hip arthroscopy, what is hip arthroscopy? So I took, this definition. Arthroscopy really is the origin of two Greek words. So arthro meaning joint, and then scopian, which I'm sure I'm not pronouncing correctly, so Dr. Diab, if he's here, he can help me with that pronunciation later, means to look. So to look inside the joint, right? And how we do that is with this camera. So, you can see here kind of in this top right-hand corner, kind of our camera has a light cord, and then it has kind of an angled lens so that we can actually look around and we can see around corners, which is actually one of the most technically hard things to do for the hip joint, just because it's kind of a really round ball and the socket is really deep. So hip arthroscopy and its use in adults has really been increasing over the past 2 decades. And just for your reference, knee scopes or knee arthroscopy probably started to become popular maybe in the 1970s. Hip arthroscopy we really didn't figure out how to do until like the early 2000s, just because of the length of instruments we needed, as well as the developing traction to actually see within the hip joint was really challenging. So this is kind of more recent development in terms of technology. Pediatric and adolescent hip arthroscopy kind of parallels that increase, but definitely lags behind our applications in the adult population and less evidence overall in the literature. And so I think we have a growing experience with hip arthroscopy as a surgical tool, and I just kind of wanted to walk through some of the reasons why we would do hip arthroscopy. So why would we do hip arthroscopy when open surgery has existed for centuries? So I think these are some of the pros and cons, and this photo here at the bottom is a picture kind of inside the hip joint. This is the femoral head, this is the acetabulum, and this is the labrum here. So one of the biggest benefits is that it's minimally invasive. So we can do a lot through 2 small keyhole incisions that are about 1 centimeter wide. So they're about the width of my pinky, 2 small incisions, about the size of a pencil. Less morbidity, so less soft tissue dissection equals less scar tissue, and then that allows your patients to potentially recover faster and rehab faster. And then I actually think the visualization is actually much better than doing an open surgery. So you can access a lot of the same parts of the joints doing open surgery, but I think the visualization actually is much better with a camera. And we pump in sterile saline into the hip joint to be able to see, and that really gives us a really nice view of the hip. And I'll show you guys some photos and videos of that in a moment. What are the cons of hip arthroscopy? So it's technically demanding. So a lot of sports medicine surgeons don't do hip arthroscopy. It's because it's hard. The learning curve is really steep, and it's much harder to do than knee or shoulder arthroscopy. It's kind of limited to certain areas of the hip. So you'd like to think, hey, you can see everything. I just told you can see really well. You can see really well, but just parts of the hip. You can't really get to the inferior part of the hip. It's really hard to, you can see, but you can't really access some medial parts or inner parts of the hip joint. And then you do need some special equipment. So you need a special table, which I'll show you some photos of, just to be able to get the hip distraction. And you need a different scope than what we use in the shoulder and the knee. So just some technical differences there. So what conditions can we treat using hip arthroscopy? So these, some of which you've heard kind of from our prior speakers this morning, Dr. Swarup as well as Dr. Ramirez, but definitely hip arthroscopy is most commonly used in the adolescent patient population for femoral acetabular impingement or hip impingement as well as labral tears. You can use it to irrigate a joint or do an irrigation debridement for septic arthritis. You can use it after SCFE or slipped capital femoral impingement. So these are patients who had a slip of the femoral, epiphysis at a younger age, and then oftentimes you probably heard from Dr. Swarup this morning that we do what's called in situ screw fixation. We put a screw across to stabilize that fracture, essentially, of the growth plate. But then they're left with kind of this bump or deformity that's a different type of impingement than FAI. So you can use arthroscopy to address that, and oftentimes those patients also will have labral tears. Perthes disease also is an option, for treatment for, hip arthroscopy. And essentially, Perthes, as you may know, is a condition where the blood supply to the femoral head is altered. So you can use hip arthroscopy to do treatments such as debriding loose cartilage flaps, removing loose bodies, and then if they have any deformity to the femoral head, you can also reshape that. In terms of hip dysplasia, kind of treatment of hip dysplasia, really not in isolation, but as like an adjunct, and I'll talk more about that in a moment, or kind of complementary for some of our open procedures. Some patients, adolescents or kind of young adults may sustain a traumatic hip dislocation. So these are people after a sporting event or maybe after a car accident, they get that dashboard injury, they dislocate their hip. Most of the time they'll have a labral tear, so you can treat that labral tear using arthroscopy. Oftentimes they may chip off a piece of bone as well that we can also remove during arthroscopy. I already said that. For tumor, depending on the pathology, hip arthroscopy can be a useful tool for either biopsy or diagnosis. Typically, I would say for more benign processes. So these include conditions like synovial chondromatosis, which is kind of a cartilage formation, abnormal amount of cartilage formation where basically you have lots of little cartilage bodies all over the hip joint, or pigmented villonodular synovitis, PVNS. You can get that in the hip as well, and I think arthroscopy is a great way to treat some of those benign tumor conditions. Inflammatory arthropathy, so kind of your inflammatory arthritis, not kind of classically used for arthroscopy, but we can obtain kind of like synovial tissue biopsies, which can help our rheumatology colleagues with diagnosing these conditions. And then finally, sometimes extra-articular procedures. So all the previous things I talked about were all things inside the hip joint. You can use arthroscopy right outside the hip joint as well to kind of treat tendons or other structures right nearby, such as the gluteal tendons, hip flexor tendons, et cetera. And so what I wanted to do is talk about some of the most common indications for hip arthroscopy. So a lot of this talk will focus on FAI and labral tears just because that is by and far the most common reason to do hip arthroscopy in this patient population. So I know Dr. Ramirez talked a bit about this, but in terms of femoral acetabular impingement, it really affects a wide range of patients, starting from kind of the adolescent patient up to kind of middle-aged patients. And typically presents as kind of more of a chronic groin pain, less commonly with acute pain. They often don't describe any sort of specific mechanism. So they'll just say, hey, I'm having pain in the groin, or hey, I'm having pain kind of deep in my hip. And in terms of what FAI really is, it's an intra-articular impingement. So you have these kind of repetitive abnormal contacts between the acetabulum and the femoral head-neck junction, as you can kind of see here in this animation. And through that abnormal contact, especially in the adolescent age group, that's kind of where the growth plate ends. So what will happen, well, the body will actually deposit more bone here in the front where that contact is as a result of that chronic stress over time. So you can kind of see how this area looks thicker here at the top. So that's a developmental change. That's not something that they're born with. Actually, if you look at the natural history studies and look at x-rays when they're 11 years old and then get an x-ray again when they're 18 or 20, you actually see this bump develop. So again, a developmental issue. And the problem with that bump is really puts a lot of shear force on the cartilage and labrum. This can lead to labral tearing, cartilage injury, and then eventually you get things like arthritis. And so that's one of the most common, kind of trajectories. So this specifically is referring to those that are familiar with cam impingement. Pincer impingement, where you have an extra deep socket, is a separate pathology, but they can lead to kind of similar symptoms. Now, we refer to patients that have the constellation of both symptoms and imaging findings as having femoral acetabular impingement syndrome. A lot of people may have X-ray findings, and they can have, femoral acetabular impingement findings on X-ray, but to make them clinically relevant or to actually have symptoms, we refer to it as syndrome. And really, the severity of injury really correlates with the time to diagnosis. So a couple interesting things I thought I wanted to ask if you knew that the average delay from onset of symptoms to diagnosis of this problem is about 3 years. It's a long time. And then patients typically see an average of about 4 providers before any diagnosis and referral to a specialist. So kind of through talks like this, as well as just keeping an eye out, we were hoping to kind of educate some of our primary providers who see most of these patients for musculoskeletal complaints, kind of what to look out for and when to kind of refer. I think what's really interesting is that femoral acetabular impingement is actually really, really highly prevalent in athletes. So we think that those who do sports at a younger age tend to be more prone to developing this condition. If you got X-rays of all the players at the NFL Combine, about 90% of them had at least one sign of FAI. 75% of elite hockey youth athletes with a cam bump, that's a bump on the femur, on their MRI. Really, really common also in soccer players. These are elite soccer players, 72% of males and 50% of females. And then they did this interesting study where they looked at kind of high-level male athletes and compared them to same age group males that didn't play sports, and they're 1.9 to 8 times more likely to have femoral acetabular impingement or cam bump on their X-rays. And so I think that, this is out there, this is common. Not everybody has symptoms from it. So, just be on the lookout. And then talking a little bit more about some of the soft tissue structures. So the hip labrum is a protective ring of fibrocartilage. And this diagram here kind of shows the femoral head removed from the acetabulum. And then you can kind of see this bumper of soft tissue around the acetabulum. So that is the labrum. And its job is to contribute to hip stability as well as the suction seal. And labral tears are really, really common. So present in over 90% of patients in FAI, and they can cause pain as well as mechanical symptoms. They're so common, in fact, that it's actually been suggested in our literature for people who do hip arthroscopy that if you have femoral acetabular impingement on X-rays, you maybe don't even need to get an MRI. I mean, we still get the MRI, but you almost don't need to because you know what it's going to show. And it's going to show this, which is, again, labrum up here with the probe in the labral tear, a flap of cartilage. So remember I talked to you, when you start to get the labral tears, you start to also injure the cartilage. And so this patient, essentially when we're going inside the hip at the time of surgery, we're kind of expecting to see the labral tear. We know what we're going to see. And so why do we care so much about it? I told you it's really common, but most people don't have symptoms from it. What's really, we care about it, especially in our younger patient population, because it's actually one of the most common reasons for early onset hip arthritis in those under age 50. So this X-ray, you can kind of see a bump here. So this patient is a little bit older, in their 40s, but they actually had femoral acetabular impingement signs on their X-rays, and then they subsequently got hip arthritis. And now this hip is, too far gone, unfortunately, to benefit from a hip arthroscopy or hip scope, and this patient's probably going to be talking about a hip replacement at a young age at this point. And so this was an interesting study that came out last year that looked at, and I told you that we've been doing kind of modern hip arthroscopy for 2 decades now. So when we do it early, what happens to those patients in terms of the natural history versus those that have the cam deformities we said, are more likely to develop arthritis. So this was a study at HSS that looked at about 100 patients with 12 years follow-up, which is really, really hard to do. So kudos to them. And they compared the operative side to the asymptomatic opposite hip. And the operative side, they had a relative risk reduction for developing OA on X-rays of about 42%. With the risk factors for OA progression, they found in this study to be patients who had a slightly shallow socket, who were older, had worse arthritis at the time of the scope, and bigger bumps, worse cam impingement. The limitations of the study was that it primarily looked at x-rays, did not really correlate that with the patient-reported outcomes or how, kind of how the patients were doing clinically. But we do think that modern hip arthroscopy does likely help prevent the development of hip arthritis, at least on the x-rays. In terms of how patients are doing clinically, that's kind of still be determined. In terms of clinical presentation of FAIS, we classically talk about groin pain. So, patients will kind of describe pain kind of in the front or anteriorly. They'll also sometimes show you like this C. They'll say like, without prompting, they'll say, it hurts like this. Typically they'll say pain worse with sitting, worse with sports and activity. Constant pain or night pain, much less common. They'll sometimes describe kind of mechanical symptoms like hip popping. On exam, which we'll go over at our session with myself and Dr. Ramirez this morning, really limited hip internal rotation compared to the contralateral side, a positive flexion, adduction, and internal rotation test. I like the name of this test because unlike other tests, it actually tells you what you're supposed to do. So flex, adduct, internal rotate. And then scour, which is a test, I'll show you here in this video, but basically kind of like a McMurray's of the hip, but you're kind of sweeping the hip in a circle, trying to catch that labral tear and have it be painful. So this is a video of me doing a fader, and then this is like kind of the scour portion of it where we're kind of sweeping the hip in a circle. And we can practice this during the physical exam session. These patients may also have pain with kind of axial loading of the hip. So if you have them do a straight leg raise, just have them lift their leg straight in the air from the supine position. They'll have pain in the groin. And then a Stinchfield test is kind of resistant straight leg raise. So how do we as orthopedic surgeons diagnose femoral acetabulum impingement? So this was a survey, interesting kind of international survey done, and the most common ways to diagnose FAIS was history of groin pain, 80% of surgeons, and then decreased hip internal rotation. And then here you can kind of see this fader test. So I think, if you just keep these two things in mind, that'll actually clue you in to kind of this pathology. And then I think that, imaging is really important, and because I'm a surgeon and because people are coming to me with conditions such as this, we always get x-rays first. I get them before patients show up, which is actually one of the biggest complaints of our group is that why are you getting x-rays before I even meet you? And I think the reason is because we see pathology like this. We see arthritis. We see this cam bump. So I'd encourage you, for those of you primary care physicians in the audience, if you have someone with groin pain or other musculoskeletal pain not getting better, I would encourage you to check an x-ray. I think it's worthwhile and can really clue you into certain pathologies. So in terms of the x-rays, I like to get two different views, so AP as well as a lateral. This is an AP x-ray here of the right hip showing this cam bump or cam deformity. You can kind of see how there's like a prominence here. And then this is that same patient's MRI. MRI is helpful to show the soft tissues such as the labrum as well as some of the cartilage and other structures. The labrum in cross-section is kind of this triangular shaped structure, and then you can kind of see this is a MRI with arthrogram or with dye injected. And this dye injection does help kind of highlight the labral tears a little bit better, so you can see that dye kind of going between the labral tear and the acetabulum. A lot of the MRIs that I get now are actually without the dye contrast, which is a little bit more comfortable, obviously, for the patients. And I think that the arthrogram does have some role, but most of the time now, especially with the MRI scanners at most kind of modern hospitals, the plain MRI without contrast is usually sufficient to see any labral pathology. So I think non-operative treatment of hip impingement is always indicated both in my adolescent and adult patients, and typically consists of anti-inflammatories, activity modification, as well as a really good structured physical therapy program. A lot of patients with hip pain also have things like low back pain, glute weakness, and difficulty activating their glutes. So I think it's really, really important to get them to a structured PT program. And as mentioned before, it matters that they're actually doing the PT besides going to the PT sessions, because going 30 minutes a couple times probably isn't enough to make a huge difference. And then as Dr. Ramirez mentioned, if there's any question at the diagnosis, if they have pain in multiple areas, groin, lateral, buttock, low back, or if we're just trying to, give them some temporary relief so that PT is more effective because their pain is prohibiting them from actually doing the exercises, an intra-articular injection can be really helpful. So how do adolescents typically do if we treat them non-operatively? So this is a study out of San Diego, and actually they showed 82% of adolescent patients with hip impingement did well and had improved outcome scores at 2 years. So 70% of them they were able to manage with physical therapy and rest. 12% of them that were having too much pain to do the PT had a steroid injection along with that. So I think this is a nice number to kind of explain to parents and patients, hey, 82% of people with your condition can get better without surgery. That means, right, 18% of them didn't. They went on to arthroscopic hip surgery. In terms of follow-up, at 5 years, those who were treated non-operatively still had relief of their symptoms. So it's not like, hey, I get better for short term, then I have to have surgery. So I just like to kind of keep this in mind. And then, should we be operating on hip impingement in adolescents, given that so many of them do improve with non-operative treatment? So those who failed non-operative treatment, there are multiple studies now that do support patients do well after hip arthroscopy. They typically have improved function, pain, as well as satisfaction. And this is really interesting. We have very little data on this, but they may have actually better clinical outcomes than adults. The failures seem to be associated, so these are people who had hip arthroscopy not happy afterwards or can't do their sports afterwards, seem to be associated with female sex, global laxity, so these are patients who have ligamentous laxity, and then a longer duration of time prior to surgery. So remember back to those, that kind of delayed a diagnosis, patients who've had pain for many, many years. So I think this is interesting. I think still more research to be done, but definitely my algorithm is kind of trial of non-operative management for at least several months with a good structured PT program, medications or injection if they need it, and then those who are not better, go ahead and refer them or talk to them, in my practice about surgery, kind of the benefits potentially. And so I wanted to share with you all kind of what surgery looks like. And so the surgery is called hip arthroscopy. So again, looking inside with the camera in the joint, repairing the labrum, and then acetabuloplasty refers to shaving any prominent bone on the the acetabular side. Femoral osteochondroplasty refers to shaving any prominent bone or cartilage on the femur side, and then I typically close up the capsule at the end, and the capsule is a set of ligaments that's just right outside the hip joint. You have to typically go through the capsule to get into the hip. And so this is a diagram here looking at some suture anchors. These are really small devices that are attached to non-absorbable sutures, and the sutures we can loop around the labrum to repair, and I'll show you some images of this in a moment. And this is the typical setup. So like I said, requires some special equipment. This is a special table that we can actually x-ray through, and then their feet are placed in these kind of boots that actually have BOA attachments. So those of you snowboarders in the audience, you know what that is. So actually we use that to actually secure their feet, and then while they're asleep, pull on that limb, and that helps us get the distraction, so actually we can work inside the hip joint. So this is a picture of how we get inside the hip joint. So we actually inject air first, and you see this is a needle here, and then once we inject air and then pull on the hip, again, while the patient's under anesthesia, we can see how there's distraction of the hip, and that's the only way we can actually get in and see inside the joint and do all of our work. And then, these are just some images of how, put the camera into the joint, and then through another small incision, I'll actually be able to, so one incision for the camera, then another incision for all the instruments. And this is kind of what the hip looks like when you first get in there. And I just wanted to share kind of a video of what the inside of a hip looks like. So on the left-hand side, the round ball that looks like the moon, that's the femoral head with some normal cartilage. And then on the right-hand side is the acetabulum. And the acetabulum is interesting. Only part of it is covered with cartilage. You can see here in the center, this is kind of the fovea region. So that's a normal area that does not have cartilage coverage. And then around the perimeter, you'll see the labrum, which is kind of over here on the side, going all the way around. And you can see this patient kind of has a labral tear involving here, and then a little bit back here as well. So this is a different patient's hip. This was a 15-year-old football player who had maybe a year or two of hip pain. It was to the point that he was not able to play his sport because his hip was hurting. We did do a diagnostic lidocaine injection pre-op just to confirm that the hip joint was the cause of his pain, and it did temporarily alleviate his pain, so that was helpful. And then getting inside his hip, you can kind of see here again, labral tear here in the center. This is the repair process. So I've already placed a suture anchor into the acetabulum using a little drill pilot hole, and then the blue and white stitches are what's going to be used to repair the labrum. So now you can see how the labrum is no longer torn or drooping into the hip joint, and then this will stabilize it, protect the cartilage from future injury, and also alleviate his pain. So I do this portion of the surgery while the hip is on traction, and then we put the femoral head back into the acetabulum, and this is a picture of that, again, same 15-year-old football player's hip, kind of a cam deformity or bump here on the side, and then using a burr to kind of smooth out that area of the cam bump. The burr looks really humongous, I tell all the parents, but it's about 5 millimeters, so it's like half the width of my pinky. So it's just really magnified. And then this is kind of after the cam deformity resection, and then you can see the labral tear over here, and then we move the hip under anesthesia, take some x-ray shots just to make sure that the cam bump is no longer bumping up against the labrum and causing the labrum to re-tear in the future, for example. Okay, so in terms of rehab after treatment for hip impingement and after hip arthroscopy, the rehab is long, is what I tell people. I know some people may be familiar with like a knee arthroscopy, meniscus trimming. That's a totally different surgery, okay? So for my patients, usually there are crutches and in a brace for about 3 weeks. We'll protect their range of motion, so kind of let them flex up to 90 degrees, but really protect rotation for a few weeks, again, just to let the capsule and labral repair heal. Physical therapy, I think, is super, super important. So I know there's some physical therapists here in the office, or here in the conference today. But I like them to go at least 1 to 2 times a week, working on range of motion, normalizing their gaits, really focusing on pelvic stability, strengthening their glutes and core, and then kind of doing this progression in terms of running, agility, and then finally sports-specific drills. So running at 3 months and then contact sports or full return to sports no sooner than about 5.5 to 6 months, so that, you know, football player was telling you earlier, he was doing exceedingly well. He and his mom convinced me to let him go back at about 5.5 months, but like 2 weeks early, okay? So, and he was meeting all milestones in terms of strength and agility, et cetera. So this is just a general timeline. Some patients do need longer than this, especially those who have been painful for many, many years, who have a lot of muscle dysfunction or weakness. And then in general, you know, the outcomes after the surgery are really good. So high levels of return to sport, over 90% of patients, almost as many returning to the same level of competition. So they're getting back to doing things at a high level, which I think is great. And then I did want to make a little mention of when we use hip arthroscopy in dysplasia. So I mentioned to you before that we don't usually do hip arthroscopy in patients who have really shallow sockets, just because we're not really addressing the 3-dimensional deformity. But we can use it as an adjunct procedure with some of our other kind of acetabular osteotomies as well. So I think it's a minimally invasive way to treat some of the pathology within the joint, including the labral tears and some cartilage issues. And again, typically combined, and Dr. Diab will be speaking on this in a moment, with a pelvic osteotomy to address that 3-dimensional deformity. Again, no scopes in isolation in those with frank dysplasia, because I mentioned to you pulling the traction or distracting the hip. You try to put it back in, and interestingly, we just had a case of this yesterday, Mohammed and I, where we did a combined surgery, and that patient, her hip, so she's mildly dysplastic, but after the traction portion of the procedure, her hip was sitting like partially out of the joint, no matter what I did. So I was very glad that we had decided as a group, kind of our hip preservation group, to do the osteotomy in that type of patient, because a scope alone actually can make them worse, even though we think we're treating the labral tear. It's not really addressing the bony kind of deformity. So what's interesting is the labral tear that patients get in dysplasia is a little different than the one that you get in hip impingement. So hip impingement, bump on the side, bumps up against the labrum and kind of pinches it and then tears it. In hip dysplasia, because the socket is shallow here, the hip is always trying to kind of sublux. And what you get in that case is actually a tear that starts from inside the joint and propagates outwards. So we kind of call this an inside out. This is kind of very detailed, but for nerdy hip people like myself, I think this is kind of interesting. Like different etiology, it'll still look like a labral tear on the MRI. And then this is a patient who has a history of hip dysplasia, and her tear is much more subtle, but it's actually on the back side of the labrum. So you can see here how it's kind of lifting up at the cartilage junction. So this is actually a tear, even though you can't see it from the kind of inside of the joint. And then just to kind of wrap things up, I wanted to share kind of an interesting case. This is also a patient that Dr. Diab and I took care of together, but a 16-year-old female figure skater who came to me with bilateral hip pain as a referral from one of my primary care colleagues. And she had these x-rays. So for her right hip, we actually elected to do a combined surgery with both hip arthroscopy, a labral repair, and then an open periacetabular osteotomy. And not to steal any portion of my colleague Dr. Diab's talk, but the periacetabular osteotomy is essentially making cuts here, here, and here, and then rotating the socket over to provide more coverage or to deepen the socket. And that's really oversimplifying it. And then, I did the arthroscopy portion at the time of that surgery as well. So these are her x-rays kind of after, and you can see how this hip, the femoral head is much better covered by the socket now. You see how on this one it's kind of uncovered. So she did really well with that right hip. And then her question to me was, do I really have to have, I'm feeling really good with the right side, but do I really have to have that big surgery on the opposite side? And if you look at her left hip actually looks a little bit better covered, and we have special measurements we'll take. So we decided to do just the hip arthroscopy and the labral repair on her left side. These are some pictures from her left hip. You can see a labral tear here. And then, after the labral repair, and she's about 4 months out from her left hip, Mohammed, just for some follow-up for this one. She's back to ice skating, has no pain in either hip, and is actually quite happy. So I think this is one example of how the decision-making can be a little bit complex, but when we do the right surgeries for the right condition, I think, you can have kind of a happy patient getting back to kind of their sports. So in terms of take-home kind of final thoughts, hip arthroscopy has multiple applications in our pediatric and adolescent patient population, and really helps with our visualization, less invasive. It is technically challenging, so I think it's one thing to consider. And the rehab process is quite involved. The outcomes are typically excellent for those patients, in my opinion, who are indicated well and have femoroacetabular impingement syndrome. But really more research needs to be done on outcomes, specifically in our adolescent population. Most studies are kind of grouping all comers together, and that includes adults, up to age 40s, et cetera. So, yeah, these are my references additionally. And then in case anybody needs my contact, I'm here, and then we're happy to take some questions after Dr. Diab's talk.
I see everyone decide to leave when I came to talk, which is good. I'm gonna relieve Dr. Watkins of introducing me because I have to stall a little bit because we've got to get my presentation up. So my name is Diab, D-I-A-B, and I've been here since I came to UCSF in 2002, having been at the University of Washington. I apologize for this. I had my talk ready, but it's on a computer that someone doesn't have anymore. So I apologize for that. But while I'm doing this, I'm supposed to talk about open hip surgery, which to a primary group I can't imagine would be interesting. So I'm going to ask you questions instead, and I'm going to show you a case. Can somebody tell me define the hip in one word? Begins with J. Come on, try. Joint, thank you. It's where one bone joins another. The questions get more complicated. Seriously? I gotta do it. All right, so what kind of a joint is it? Yeah, ball and socket, exactly right. Exactly right, ball and socket. Why do you have a ball and socket at this location? So you can put your foot in space, all right? As you get further and further away from the core, the joints become more and more restrictive. So your finger is just in one direction, okay? Your elbow is in one direction, but your forearm goes this way, but you need two of them. The hip, you can do it all. So where else do you have that? What's that? Shoulder, exactly right. The shoulder, same thing, same concept, right? Okay, so can you guys see this? What I'm doing right now?
Not yet.
Oh no, can you show them to them? I want to show them this. Okay. Oh, you can't. Oh, you can't.
Yeah,
oh,
yeah. Not until you.
All right.
We'll load
That's
it.
okay. The good thing about this is, unlike Dr. Wong's talk, which was so good, the clunkiness of this will keep you awake. So, and I've put together this image library of cases, and it's so rich that it's like 1 million clicks to get to any one talk. That's why probably one of the reasons why people don't use it. But I've got a talk here that's really quite good. It's a case with this concept that, and I'm going to download this. Is that correct?
Yep.
Okay, great. Do you want to take over from here?
Yeah.
Okay, great. So while he does that, so you've got a shoulder joint that's ball and socket, right? And you've got a hip joint that's a ball and socket. But they're different. Okay, I know that this idea that, oh, orthopedics all the same, just banging away in the OR. It's not. There's a lot of subtlety in orthopedics. Does anyone know any difference between the shoulder and the hip? If I ask you, I'll ask you a different way. The shoulder is a what tissue-dependent joint? What tissue does the shoulder depend on more than anything else? Has anyone ever had shoulder surgery here? No one? That's impressive. It's a muscle-dependent joint, which is why everyone's complaining about their rotator cuff. Right? Earlier today, Dr. Swarup was talking about, well, you'll be okay until your 5th and 6th decade. Well, I'm in my 5th and 6th decade, and I'm nervous about my hips. Is it there now? It's ready to go.
There you go.
Good. And is it presentation?
Sure.
Yeah, great.
Yep.
Okay, good. But let me just finish this, because it's an important detail, just so you guys understand what we talk about in the hip. The shoulder is a muscle-dependent joint. So the most operations you do on the shoulder are rotator cuff. You do other things, but that is the most. What is the knee? Now that you've heard me say the operations you do the most are, what is the knee? What tissue does it depend on the most? What are people getting on their knee? Ligaments. ACL, right? Come on, all the pro athletes, right? So the knee is a sloppy joint, and it needs its ligaments. Ligaments are tissues that attach one bone to another. They're not tendons. They're something different. But the knee needs that because it's very sloppy. Okay? The hip is a what tissue-dependent joint? Not labrum. Labrum is important, but not labrum. What tissue does it depend on? Bone. That's why we do all this bone work. We're not doing ligament work on the kids with hip problems. It's all osteotomy, So anyway, and I'm supposed to talk about osteotomy, but I can't imagine talking about that to you guys. So I'm just going to show you a case. So you can see this first slide, correct? And the patient is 4 months old in the first image. Does anyone see anything on there that's abnormal? Why is she in a Pavlik harness? Yeah, and it says here Barlow sign. So Barlow is a man who wrote a paper in the 60s. It's unbelievable to me. I still don't believe that he did it, okay? I suspect him. But it's a classic in our world, Barlow. And he wrote a paper where he examined 9,000 hips. I can't imagine examining 9,000 hips, all right? And from that paper came many things. And it's a really good paper for us. But one of the things came his technique of checking for hip instability. So Barlow, the ball is in, and you bring the legs together, and it slips out. Ortolani before him had said, when you open the legs, you can feel the ball clunk in. Okay? So this girl was Barlow positive. She rested, located, but she could slip out. All right? But if you look at her x-ray, it's not great. And what do we look at? If I look at this bone right here, can you see my cursor? Ah, blast. Okay. If I look at this, it kind of points here. you may think this is subtle, but to us we notice. If you look at this, it kind of puts it a little bit to the side. It's not dislocated. It's subluxated. So subluxated is sub meaning a little bit less than, luxated, dislocated. Okay, so it's a little bit out. It's in the socket, but it's kind of sitting on the rim. So we treat that. Okay, because we need the ball to be in the socket. The hip is a bone-dependent joint. It has to fit precisely. The knee doesn't have to fit so great. The shoulder doesn't have to fit so great. Okay, but the hip has to fit exactly. Okay, so even a little bit off, we don't like it. Okay, and so she's in a pelvic harness because in the first 6-ish months of life, we put her in a pelvic harness. Pelvic is a guy, it's not a pelvic harness. He's a Czech guy who wrote this paper in the 50s. So pelvic harness. And even here, she's just still a little bit. This specific nucleus is smaller than this one. The acetabulum and the femoral head stimulate each other. When you have an ill hip, the ossification is delayed because the forces are abnormal. So we see that and we go, oh, it's a little bit too small. A teeny bit sitting out. And these are subtle, but we keep her in her hip abduction brace. And then by 2 years of age, we'll make a surgical decision to cut the bone or not. And she looked pretty good to me there. So I left her alone. All right. Are those useful, those x-rays? Do you guys feel like you understand those x-rays? And then I followed her. So why do we, I mean, she's normal at 2, so why do I follow her? I mean, she's normal. So the problem with hip dysplasia as a diagnosis is once we get our claws into a patient with hip, we won't let go. Okay? And I actually think that's an issue because let's say someone comes to see me with a hip ultrasound for breach. You heard earlier in hip dysplasia, a British, I'm an American product, but a British, I'm now referring to 2 people from Britain. Another British surgeon said there are problems of production and problems of packaging. So problems of production are genetic, inherent to family history. That's your big risk factor. Problems of packaging are external. Production, intrinsic, internal, genetics. External, breach. So why is breach a risk factor? I think most people will get that genetics is a risk factor because it's familiar in every disease. But why is breach a risk factor? Yeah, what about the position? Why? So you can still deliver the. Okay, so legs are up. You're describing breach. You're telling me why.
Adduction.
Yeah. So adduction would imply that the ball's going to dislocate. No, they can be in. But I just want you guys to understand because a lot of what we do is based on this principle that one bone stimulates another. So in the previous X-ray I showed you the ossific nucleus is a little bit small. So that's something that we pay attention to. So when you are, so the socket is like this. In the middle of the socket is a growth center. It's called a triradiate cartilage because the hemipelvis has got 3 bones and each one contributes a growth plate. That's why it's triradiate. Okay. How do you stimulate that? By doing it by being like this. That's why your pelvic harness. That's why your abduction brace. Everything is up and out. Because here's my socket. As I stand, this is my socket. You guys can't hear me. Damn it. No, I'll carry this. I'll just carry this. I'll carry it. So as I stand, this is my socket like this. So how am I going to stimulate my socket? I want to be orthogonal. So I need to bring my leg out like this. If I am breech, I'm like this. That's a completely different force. Okay, so that's why breech has a higher rate of hip dysplasia. Because the child, and so think about it, it's not just I was breech for a day. You have to be breech for a while, okay, because you're in the molding process, all right? And so we get a patient who has been breech for a month, and they get an ultrasound. And what we know is that ultrasound raises the rate of hip dysplasia by 10x. okay, which is problematic. Okay, which is why I do my own ultrasounds. With respect to the radiologist, I just do my own ultrasounds because I don't want to give the patient a diagnosis of hip dysplasia. Because if I do, I have to follow them until maturity. Okay, so I do my own ultrasounds, and we get this because you will see a patient who has an alpha angle of 55 degrees. I don't want to call that hip dysplasia. I just sort of say, hang in there, come back and see me, we'll check again. The problem is now they have a radiology report that says, and I'm not criticizing radiologists, they have to do this, they have to report what they see. Okay, you ask them for a test. In fact, you'd be worried if they didn't, right? But now it's in there, and then it's the controversy of whether or not they have hip dysplasia, all right? Because once we have hip dysplasia, follow them to maturity. So why do we follow them to maturity? Because she looks normal here. She looks normal here. She looks normal here. Why am I continuing to bring her back and look at her x-rays? Because it's like the growth charts. So you get plotted on a growth chart, and the next time they check your height again and your head circumference again and again, and every time you're 50th percentile and again, because you could fall off the growth charts. Okay, so she looked great, and we just follow them at intervals. There's no right number for intervals. As a broad thing, if we're treating them early, we're watching them a lot. And then we try to extend the intervals. But a critical interval is 6 months. So the pelvis x-ray at 6 months is gold standard. Another critical time point is 2 years, because that's when we start operating on bone. Everything after that is variable according to the physician. Okay, so I'm not right or wrong or anybody else, so I try to space them out. And then this is what she looked like. So can you guys describe this? Can you guys see? It's a bit faded, but can you see anything there that's abnormal? Yeah, exactly. You know, the patients get on my case because I won't tell them their Cobb angle for scoliosis. And I won't tell them what their acetabular index is for hip dysplasia. I kind of do what you do, which is it looks a little bit lateral, because it is abnormal. And I'm worried about trying to put exacting numbers on things that are not that precise. But you can see, we just said that the hip is very constrained. The hip and the ankle cannot tolerate any deformity, okay? And this is just a little bit out, and it's uncovered. So we talk a lot in orthopedics about uncoverage, okay, or cover. Okay, so I'm gonna take a poll from the audience. By the way, I don't have an agenda here. I can just talk, you know, and if you guys have questions, you can ask me questions, all right? But I'm gonna take a poll from the audience. Who, when they go to an ice cream parlor, what do you guys like? The ice cream in a cup or the ice cream on a cone? How about in a cup? Oh yeah, yeah, that's right. Okay, what about on a cone? Okay, so one of the things I do when I get the ice cream on the cone is I immediately nibble the little bits around the rim, right? That is hip dysplasia. If you can remember that, you will not forget hip dysplasia. Seriously. And this is what I say to the families. So we talk about something called edge loading. That's a kind of biomechanics physics thing. But when the server takes the cone, assuming they have a scoop, not one of these like fancy Italian things, but a scoop, and they push down the ice cream on the cone, everything inside that scoop is smooth. You agree? Everything on the edge bulges. Well, that's this. This is your scoop, and this is your ice cream. So what's going to happen on that edge? You're going to get edge loading. And that's the whole game in hip dysplasia when we operate on them. You're trying to get the ball to get inside the socket. And we want it to be concentrically reduced. Concentric. The center is con, just a Latin prefix, meaning the same. So the center of the socket, if I do a circle with the socket, the center is about here. The center of the wall is a little bit out. Okay, and if it's not concentrically reduced, it's going to be a little, as you said, a little bit out or uncovered. You're going to get edge loading. Okay. The other thing is, do you think it's wider here than it is here? Yes. It is, right? Okay, so this brings another sort of concept in my world. Does anyone know why motorcyclists wear leather? It's not a mystery, but did it ever occur to you? Aside from the fact it's stylish. Yeah, exactly, exactly. So what happens when they come off their motorcycle? They slide. Someone say slide? Yeah, they slide, right? They slide. So they want the leather to slide. Because what can their skin not tolerate? Shear. Can't tolerate shear. You'll rip your skin right off. You know another tissue that can't tolerate shear? Cartilage. In fact, cartilage doesn't really have any blood vessels going in. It works like a sponge. It likes to be compressed. And then when you relieve the force, not too much, okay? But compress, and then when you release, in come the nutrients, okay? And so when you look at an x-ray like this, and you see a gap, there's a little bit too much this way versus this way, this wall, every time this girl walks, she does axial load, compression, I like that. Shear, I don't like that. Over and over all day. Shear, 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 shear all day. And she'll wear herself out. And you can see she's beginning to get a thinner cartilage lip here. And you can even see that the ball is no longer spherical. She's only 13. Okay? So that's another thing that we look at. If it's a little bit out or uncovered, we're worrying about edge loading. And if the socket doesn't fit the ball, we're worrying about rattling in the socket, which is going to give you shear. Okay, so anyway, so she came back at me for the final x-ray, and I get the final x-ray at maturity. And what is maturity? I mean, a million ways to define it, but I think for girls, get your final x-ray after menarche. You figure they're pretty grown up by then. And if they look good, then you're done. For boys, maybe when they start to shave, something like that. Not regularly, but just at least they've tried it once or twice. Okay, so I'm supposed to, so I'm going to show you what we do, and then I'm going to stop talking, and if you have questions for me or for all of us, because I think questions are valuable, and we don't have enough time today for questions. I just put this in because I love his mustache. But I want you guys to see that, so in our world, remember that the shoulder, muscle-dependent rotator cuff surgery. Knee, ligament-dependent ligament surgery. Hip, bone-dependent bone surgery. We are not the original bone operators. Gilly was an obstetrician, and he introduced a saw to cut the pelvis for dystocia. This is from his paper, and I put it in. This is for our residents, these little vignettes I make, but I think it's interesting to you also. Imagine, poke. There's a lot of traffic in there. And somehow he would just zip it around and then zip the bone and cut it in. This is his original drawings in a German, so that he could open the pelvis. So we still use that saw, at least I do. But we're not the originators. The OBs cut the pelvis before us. But this is what we do. Now, I don't know if this is going to work. I wanted it to work. Is our AV person here? How can I get this to play? Oh, it can play. Okay, so one thing I was thinking, I was talking to Dr. Swarup about this, and I've often thought I wished that our staff, so our office staff who schedule surgery, they should come down to the OR and see what they're scheduling the patients for. And I think primary care physicians should come to the OR every now and then and see what we do to your patients. Okay? But this is kind of what we do. So this is what a bone cut looks like. Can you see the arrow there, the white arrow? That's how we cut bone. And this is using the Gilly saw. It's pretty violent, right? But that's what we do. And then, oh, no, I'm trying to get rid of this slide. And then we use a lot of X-ray because what I need to do with this is take that socket that's like this and move it to here. All right? Do you guys remember the film Hitch with Will Smith? And he's trying to teach that guy how to dance. And the guy's flailing everywhere, and he's like, no, 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 no. From here to here. And it's a lot of surgery to go from here to here. But it makes all the difference to the ball, because it takes the edge away from the ball, so it doesn't grind it down. All right? So the patients suffer for, it seems like a small move, but it's a key move. And I won't bore you, but we use X-ray. I'm supposed to talk about open hip surgery. We use X-ray in the OR, and we have to cut around the ball. And then we do all this violence. I tell the residents that surgery is controlled violence. So I thought I'd just entertain you guys with a saw. I mean, I can't change a light bulb in my house, but I can do this. And I know it seems gruesome, but I will say to you, it is so great to do what we do because we actually fix patients. When I'm done with their hip, I know that they are better. There is no equivocating. There's an Arabic expression. So the English expression is the pen is mightier than the sword. Have you guys heard that expression, right? In Arabic, they say, but the sword tells the truth. And it's an interesting thing. I know surgery seems gruesome, but it is the truth. We fix the problem. And then I'm just going to show you this. This is the kind of stuff we do. We also use mallets. And I know it seems violent, but it's very controlled, and the patients do a lot better. And I'm going to show you now just the result. And what you can see here is that the ball now is tucked under the socket. So it's a lot of work and a lot of suffering because it takes a long time to recover from these things. But this space right here, this bone from here to here was down here. This space from here to here was down here. And so you can imagine how we rotated the bone to take the socket to tuck the ball in. And that now the ball is not going to get edge loading, and it's going to be more nestled in, so hopefully it won't be shearing as she walks. Okay, I'm going to stop there, and we can have more time to do questions and stuff. That's all I'm going to talk about for open hip surgery. I don't think you need to be told any more about what we do for surgery. Does anyone have any questions for me, or we can bring or we can bring everybody up?
Yeah, if we could have all speakers come up to the table, and then, we'll take your question first. Thank you, Dr. Diab.
That's right.
When you're doing, hello. When you're doing, like, taking the watching and waiting approach, do you counsel the parents on different things they could be doing to set that hip in the right position, and different activities that the children can be involved in? Because that's totally up to them. The kid doesn't know yet, so, put them on a horse, put them in ballet, put them in other things, carry them like this instead of in the carrier all the time, things like that.
Yeah, this comes up also in spine deformity. The problem for us is we don't have good evidence that activity influences hip dysplasia, except to say that and Dr. Wong already talked about this, in the pro athlete world, FAI is way more than the general population. And what we think there is it's a growth disturbance, meaning if you actually load the hip enough to become a pro athlete, so you're doing it in high school and into college, the proximal femur just grows abnormally. And because the ASAM responds, then the ASAM responds abnormally. And some people have tried to explain this as the increasing demands require a different orientation of socket to contain the hip, because the hip is so essential to stabilizing the trunk during explosive movements. If you want to believe that theory, I don't think we know. So we know that in the extreme case, you can influence hip shape, because that's why pro athletes have got so much FAI, but we don't have a good physical regimen for hip dysplasia patients, like do these hip healthy moves. I don't think so. And I would say the same thing for spine deformity, with respect. I know that, there's an international conference of Schroth. International, people come from far and wide. And yet in our world, it's been looked at. And there was a paper in 2020 by two senior, very well-respected surgeons to look at the evidence, and they couldn't find any. And then there was a paper last year, a follow-up paper from a different group, also a good group. So we don't have good evidence for that, sorry.
Is that because we don't ask about it?
I don't know.
And we're not collecting that
Yeah,
data?
I mean, there's no question. And you could say, look, absence of proof is not proof of absence. And we get that. We get that. And for sure, there may be. It's just that we don't know. We don't have the evidence. So I don't know what to recommend to them. I mean,
It just seems to me like we should do that even if they don't follow it. To let them know if you can put the hip in this position more often than not and have it get that kind of stress, then it's going to develop accordingly.
Yeah. I mean, is your question more relating to like an adolescent or a young adult with a little dysplastic hip?
I'm referring to from the time when they're
Got it.
born all the way up
Yeah.
to, say, 13.
Yeah.
Because that's the aspect that the parent can influence.
Yeah. So I always, one of the things it's important to kind of think about, right, is dysplasia and the risk of joint degeneration. There's no linear correlation between the two.
Yeah.
So that's been shown, like clinically.
Yeah.
And just like any chronic illness, right, there's probably a multifactorial process to joint degeneration. And so I think you do have some modifiable factors, right, which is probably activity, body habitus, et cetera, et cetera. So I do counsel families on that. And I don't obviously do that in like the infant age group, like that's a little too much, too early, too much. But in the adolescent group, yes. Like you definitely see a lot of kids who will come in with mild dysplasia on x-ray and maybe infrequent symptoms. And I do talk to them about what are your goals, right, in the future? Like, is this like the figure skater who's trying to get back to figure skating? Or is this, one particular sport that they're doing, but just doing it as a hobby? Because I think that really does matter. And then on the topic of PT, I also agree. I mean, the hip is a bone-dependent joint. But there is good evidence for mild dysplasia is strengthening, secondary stabilizer strengthening with physical therapy is effective for mild dysplasia. And there's a particular group in particular, that we talk about, like the ones that have a lateral center edge angle between 18 and 25 or 20 and 25, depending on which papers you read. They actually do have a pretty good success rate with non-operative management, mostly physical therapy and lifestyle modification.
Sorry. I have a question for Dr. Ishan and Dr. Wilson. If you get a referral for a newborn with DDH and the child is dislocated, non-reducible, you mentioned possible surgery at 6 months. Are you still doing a Pavlik treatment even from the time you see them up onto surgery, or you're doing something different?
That's a good question. I think, so doing a Ortolani exam on a baby is really challenging. So really, to know if a dislocated hip, you're able to reduce it in the exam room is sometimes very hard. And so what I will usually rely on is obviously the ultrasound, but sometimes I'll get an x-ray in that kid. like an AP and a frog leg and see what happens to the hip in the frog position. You can also, there's another specific x-ray called a von Rosen view that you can try too, which abducts and internally rotates the hip. And if on those views I am seeing the hip reduce, then I would probably try a Pavlik harness in that case and see if I'm able to successfully get that hip to reduce. No one knows the data on that, but again, the risks versus benefits, I mean, there's very low risk of trying that as long as you're monitoring them, making sure they don't disappear for 6 weeks and then end up having Pavlik harness disease or whatever it might be. So I would try it if those were the cases. But in the cases of bilateral, the more common scenarios like bilateral fixed dislocations, which are really high, there's probably no benefit there to trying an intervention like a Pavlik or an abduction brace because those are not going to reduce.
I would agree. I agree with that. It is difficult in the exam room because they just look at you and they tense up and start screaming, "You're so ugly! Get away from me!" And why would they not? That's normal. But but it's true though. I mean, it is hard, right? And so one thing you could do, if you have a dislocated hip, is you can just put them in a harness. At least it's what I do. I don't want to give up. Now, if they're older than 6 months, I'm not going to waste time. But in the early period, put them in a harness for about 3 weeks. Everything in Western culture is in threes. It's the Catholic 3. So you do 3 weeks, all right? And then you bring them back and see if when they have gone home and they are breastfeeding and they are relaxed, can the hip find its way in? And the reason we say 3 is we don't want it to be too long because if the ball is out for a long time, remember one bone influences the other. So if the ball is sitting out the socket and it's stuck there because you put them in a harness or some kind of brace, it's going to rub down that edge and actually make it worse. Pavlik harness disease sounds so grim. It's just this concept of we don't want to make the dysplasia worse because it's usually a socket problem. Socket's too shallow, right? So I agree with Dr. Swaroop. Don't wait 6 weeks, right? As long as you can keep an eye on them. But I would try. I'd just put them in and see if they will just relax and come in. It's a little bit like nursemaid elbow. By the time they come to see us, they've been beaten up in an ED, somebody's trying, the intern is trying, then the R2 is trying, everybody's trying, and by the time it's hopeless. So what you can do is just put them in a sling and say, go away, come back next week, all right? And maybe just by relaxing, that nursemaid elbow will go click, just find its way in. So I think that's what this is similar here. It's worth trying, but not for too long.
I'm in primary care peds. Are you no longer recommending a full body swaddle for babies? Is that what?
When we counsel families, a lot of families do swaddle, and that's absolutely fine. We just ask them not to swaddle the legs together. So we're asking them to avoid anything that brings the knees together. Almost all of the swaddles are made to accommodate that now.
I guess I have a two-part question for Dr. Ramirez and Dr. Wong. When you do any intra-articular corticosteroid injections, do you have any specific indication for which corticosteroid you use, or is that ultimately just personal preference?
Yeah, there's some data on that, like particulate versus non-particulate. Typically for intra-articular injections, I use triamcinolone. And for peritendinous injections, I tend to use dexamethasone. There's some data that shows that there's maybe slightly less tenotoxicity for dexamethasone, so that's one that I tend to use around tendons, and triamcinolone, or others have used methylprednisolone intra-articularly. So there's some data, but it's pretty practice dependent, so you'll see a wide variety. Some providers just use the same corticosteroid for all different injections, so it's a little bit provider dependent, training dependent, but I tend to use triamcinolone intra-articularly and dexamethasone peritendinously.
Is there any major contraindication to using something like betamethasone? That was what I was brought up to do in fellowship.
No, I think that can also work as well. I think that one tends to fall somewhere in between the two in terms of particulate. And so, there's some thought that Kenalog sticks around for longer in the joint, and so may be more useful for intra-articular injections. But yeah, I have also used betamethasone in the past in my training, so I think it depends a little bit on, what you trained using, and so a lot of variability there. Yeah.
Thank you. And for Dr. Wong, is there a minimal interval that you want to wait after an intra-articular corticosteroid injection until you consider doing hip arthroscopy?
Yeah, that's a great question. And in my practice, I refer a lot of my ultrasound-guided intra-articular injections to people like Dr. Ramirez, so I defer to her in terms of type of steroid. I don't think there's a lot of strong evidence to suggest which one. But the interval between the steroid intra-articular injection and surgery should be, in my practice, at least 2 months. Some will do 6 weeks, some will do 3 months. There are a lot of studies demonstrating risk of infection after intra-articular injection if you do surgery right after. Specifically, more studies in the shoulder, so for rotator cuff, if you do a subacromial steroid injection and then they have surgery in a brief interval, associated with a higher risk of postoperative infection. So I would wait. Also, I tell people, don't you want to see if it works? Why would you do surgery 2 weeks later? We haven't even given it enough time. So if we're going down the injection route, I would say wait until we actually know if it made a difference or not. And I just wanted to bring up, I know Dr. Ramirez alluded to this earlier, but the different types of injection. We also talked about Toradol or ketorolac, which is an NSAID, as you may know, as an intra-articular injection compared to steroid. And I think steroids have really gotten a bad name. I think there was a really poorly done radiology study that said, hey, if you do a steroid injection, they're going to get rapidly progressive osteoarthritis immediately. And that is not, the take home I would take from that study. I think that study had a lot of confounders, but it kind of made it to the general public and media. And then I have a lot of patients coming in hey, I don't want a steroid injection for these reasons. There are some basic science studies that say that steroid could be chondrotoxic. But I think that if you do it sparingly with good indications, and we're not, subjecting our adolescent or pediatric patients to steroid injections every 3, months. It's a one-time thing. Hey, let's do this to help get your inflammation down, help you make progress with PT, and then reevaluate. And I think that group of patients is very different than the adult patients I see who have severe arthritis or arthritis that's, they're trying to stave off a replacement. And those patients, I think it's more of a palliative, it's a pain relieving procedure. And so that's a totally different indication. But just kind of my 2 cents. And I think, there are, we're still studying whether ketorolac or Toradol has differences with efficacy, but in the basic science studies, we think maybe a little bit safer for cartilage. Again, I think one steroid injection, no evidence that it's going to damage your cartilage or lead to long-term osteoarthritis risk.
So we're about 5 minutes into the break already. I think the questions are great. But I do want to give people that need a break, because it's been an intense first half, the opportunity to go out into the courtyard and get a snack and meet with our exhibitors if you would like. I think our speakers are happy to stay for a couple more minutes so we could continue for those, but you guys can start your break. We'll be back here at 10:50 for the next lecture. I think someone had a question. Yeah.
Thanks for the talk. For those that manage DDH, for those high-risk babies who you screen normal with an ultrasound, when do you get a follow-up x-ray? And if so, what's the ideal timing for you? Because I've struggled with this a lot.
Yeah, you're not alone. We struggle too. So generally, for ones that have significant risk factors, oftentimes that's the female breech patient, maybe family history, ultrasound's normal. There are most of us will generally recommend an X-ray at 6 months of age, and that is just to make sure that they don't have residual dysplasia at that age. There's no, and there are actually a few studies that have looked at this, and there are some AAP guidelines, but no real actual directive of what to do. And no one's actually looked at what's the positive rate at 6 months, which is probably a good study to do for somebody. Yeah.
I do have one follow-up to that. And so if you do x-ray them at 6 months, do you have an acetabular index cutoff that you like to use? Because I feel like I use 30 just as a variable.
Yeah, exactly. Yeah, I use 30 as well. So yeah, that's based off of natural history studies, both done in Europe and North America. So 30 is usually the cutoff. Yeah.
Thank you. Yeah.
Hi, I'm Darvin Fu. I'm the PA with Brian Haas up in Sacramento. A question for Dr. Diab and possibly Dr. Wong. I'd be curious to hear this spiel you give to patients and their families about the risk, or hopefully reduction in risk, of needing a total hip later on in life after having a hip scope and PAO.
Yeah, we had a visiting professor from Mayo talking about PAO is periacetabular osteotomy. Everything we do is periacetabular. We're moving the socket, but it's reserved for the mature pelvis, so the adolescent or young adult. And it's what I showed there. So the visiting professor was talking about hip preservation, and we have a hip preservation service. And I got all bent out of shape, and I made a comment afterwards that maybe we should call it hip conservation, not hip preservation, because we're setting these patients up, because you're asking, what do we tell them, for unrealistic expectations. And I gave the example of, if you want to preserve a forest, you don't enter it. If you want to conserve a forest, you can log it as long as you give it a chance to recover. And those are two very different things. One, you get to use it, but it's not going to be pristine. And I feel that way about these hip operations we do. If you have mild hip dysplasia, mild, I think you can say to someone, I'll probably bump you into the normal pool. It doesn't mean you won't have a hip replacement, you just will have it at probably the same time as someone else, if you're mild. But if you're moderate, I don't think so. I think you're going to have it earlier. Also, I think age matters. If you get your operations as a teenager, you might more easily get bumped into the normal pool. But if you're getting your operation at 25 or 30 or 35, no matter how good your hip looks on an x-ray, there has to be wear and tear. So I don't promise them that. All I say to them is, I can make you better than if you didn't have surgery. And I can make you have longer with a more normal hip than with a hip replacement. But I don't think that this is magic. We don't give them a normal hip, we just make it better. And so that's what I try to tell patients. Because it may be that I'm not skillful enough, but my patients complain a lot forever. They're just better. Now, every now and then you get a home run where they just think you're the best thing ever. But most of the time, they still have nagging pain, so I try to tell them that.
Yes, I agree. And I think that, what I learned from you is, to tell the patients, your hip is not normal. And I would love it to be normal, but the fact is that this is a condition that you developed, and we're going to try to make your hip better. We're going to try to help you stay active for as long as we can. But we don't have a great crystal ball of like if I had a dime for every time somebody asked me like, when will I need a replacement? I don't know. And that's because there's plenty of people out there in the world, dysplasia or not, who have bad arthritis. They're not getting replacements. They're not even coming to see us. They're fine. They're out there in the world. So I tell people we're really actually very bad at predicting who needs a replacement and when. And
yeah, I mean, I agree with all of that. And I think, but if you are looking for data, there is a study by Cody Wiles. It's out of Mayo and I think WashU, because they have a long-term cohort of patients that they followed. And that paper it's in JBJS from maybe 5 years ago or so. And it has a great table which looks at time to total hip replacement based on your baseline x-ray. So they look at tonus grade of how much degeneration you have in your hip and actually use that. So, just like we're saying, if you're a teenager, you're likely at tonus grade 0. You don't have much degeneration in your hip. You just have symptoms, right? And so for you, if we correct your anatomy, likely your projected risk is going to be the same as anybody else in this room. But there might be people in this room that have dysplasia. They just don't know, right? But still, your baseline risk is probably the same. But if you're at tonus grade 2 and you do a PAO, then yes, you are going to get some benefit, but that benefit is going to be much limited than the other, right? But that paper has some quantified numbers that you can, if you're interested, you could look at.
we're going down this rabbit hole here, but it's a very common question because one of the nice things about hip replacement is you don't have any nerve endings anymore. So it doesn't hurt. It's fantastic, but it wears out. So just what Doc Swarup was saying, if you don't have much arthritis, why would you want to throw your hip away? And you hopefully will be in the normal, but if you have a fair amount of arthritis, and many people have done these studies, but this, I would just, since you're in this world with Dr. House, just remind the patients that hip replacements have their own issues. So we did this paper back in 2008 because it's a common question. And what we did was we compared turnus grade and outcomes. But we show that if you're mild to moderate, you still do better with a PAO because the hip will wear out, the hip replacement. So it's not magic that you get a hip replacement and then you're good. No, because then you have to have a second one. And the second one is not as good as the first one. Are you with me? So I think it's all how you frame it. If a patient's got a long time to live, then try the PAO unless their hip is really bad, because it's still going to be better than their hip replacement. And so then when they do need their hip replacement, they'll get it at the age that they would have had their second hip replacement. Are you with me? So today, on day 0, they both have an operation. They'll get their hip replacement at 20 years later. But one will be a revision hip replacement, one will be a primary hip replacement. Probably better to get a primary hip replacement because it'll be a better hip. Do you understand what I'm saying? And so I think that I'm not trying to make them feel bad that they're like Dr. Wong said, you don't have a normal hip. I don't want to make them feel, oh my God, I crawl out of there feeling miserable. But your hip isn't normal, but we can make it better, and probably better than a hip replacement most of the time.
So I just want to thank you guys for your awesome questions. We just have about 5 more minutes in the break. I see you with your question. All of these speakers will be at the workshop, so you can ask them as well, or if they want to stay, they